Oncology Insights. And with immense pleasure, I would like to invite Program Director Dr. Venugopal sir, who is Senior Consultant Medical Oncologist and Hemato-Oncologist at Medicover Hospital, Hyderabad. For the welcome and introductory note, over to you, sir.
Yeah, hi everyone. So, a very good evening to all. So, first of all, I would like to thank you all for joining this session for today's evening. So, we have a good session, quality meetings. That's what I can say from my end today. So, we have four sessions. One is breast cancer, lung cancer, GI, and GU. So, in which we have ASCO updates, 2025 updates from breast cancer and lung cancer, and followed by renal cell cancer and GU topic as well. Uh, so with that, I think without so other last topic being HCC. So I think we'll go ahead with the first talk from Dr. Venkat Sampath sir. Yeah. So basically 2025 breast cancer updates. Yeah, you can start, sir.
Sir, would you like to share from our side? You are muted, sir. Can you unmute yourself? Venkata, sir, you are muted.
Yeah. I'm about to share my slides.
We'll share from our end, right, sir?
Can you see the slides? I have already shared.
It's coming.
Sir, your slide isn't visible. If it's okay with you, can I share the slides on your behalf?
Okay, you can start sharing.
Oh.
His MacBook, the same problem. Yeah.
Okay. So good evening, everybody. Today I would be speaking on the breast cancer journals that were presented at ASCO. I mean, breast cancer trials presented at ASCO 2025. So the title is From the Lens of ASCO 2025 Breast Cancer. Next slide.
Yeah. Can you move to the next slide, Avni?
Sir, is it visible?
No,
Hello.
in the
Visible.
first.
Next slide is not visible.
Just a second, sir. Now?
No, this is the other topic. This is Dr. Rekha's slide deck.
Shall I try to share once again?
Yeah. You can do, sir, from your end once. Just try once.
अरे यार सब सब पसड़ आ चुका
Daud can share. Okay, sir. We can just click.
Sure, ma'am, I'll try.
Can you see the slides?
No, no, not visible.
No, sir, not yet. Daud, can you share? Sir, just give us a minute. Daud, can you share the slide? Daud, share the slide.
Yes, ma'am, wait a minute, I'm sharing.
Go to next slide. Yes, sir. Is it visible now to you?
Yeah.
Yeah,
Can see.
sorry for the delay. Sorry
No
for
problem.
the technical glitch. So you can proceed.
Yeah. So
Go to
no,
previous.
no.
Just go to the starting slide.
I think you have put the slideshow. Resume back one by one.
Go from the beginning. So this is start from here.
No. First slide. I can
Go back.
Go to the first slide down.
No, the first slide. Go back. I think it's automatically moving. What? No, it's moving forward. Now, can you just start from beginning or otherwise? Yeah. Next slide. Yeah.
Yeah. So the first study is Destiny Breast 9 study. So here, trastuzumab deruxtecan is combined with pertuzumab versus taxane plus trastuzumab plus pertuzumab. that is THP, which is the standard of care here in patients with HER2 positive advanced breast cancer. So these are the interim results from Destiny trial, breast 9. Next slide. So when we see the study design, basically HER2 positive advanced metastatic breast cancer were included. So patients who were asymptomatic or inactive brain mets were allowed. So disease-free interval of more than 6 months from the last chemotherapy or HER2 target therapy in patients who were receiving neoadjuvant or adjuvant setting, and 1 prior line of endocrine therapy for metastatic breast cancer permitted. No other systemic therapy for MBC. So the stratification factors for de novo or recurrent metastatic breast cancer: hormone receptor positive or negative, and PIK3CA mutated. So basically the 3 arms were there. The main comparison is between TDXD plus pertuzumab versus THB. However, TDXD plus placebo is the third arm, and it is blinded until final PFS analysis. Primary endpoint was PFS, and key secondary endpoints for OS, PFS, investigator related, and ORR and DOR, etc. So at the planned interim analysis, that is this date cutoff of February 26, 2025, results are reported here. Next slide. So when we see the demographics, so the patients from across all the geographic regions were included. ECOG performance 0 and 1. 0 was 66 versus 33%. And the main thing is hormone receptor status positive. So they are more or less equally distributed. 54% were positive and 46% were negative. And the brain metastasis population was quite less in the study. So only 6% across both arms. Next slide. So the prior therapies in neoadjuvant setting, chemotherapy was received by majority of the patients, and endocrine therapy 19%, trastuzumab by 28% of the patients, pertuzumab 8%. So though it is hormone positive setting, not many, I mean only 36 to 40% patients received anti-HER2 therapy here, and first line endocrine therapy in metastatic setting was not much received. Next slide. So when we see the PFS, there is clear-cut separation of the Kaplan-Meier curves with a median of 40.7 versus 26.9 months across the pertuzumab arm plus TDXD versus THP, and there is a delta of 13.8 months, which is statistically significant. Next slide. So TDXD plus P demonstrated a statistically significant and clinically meaningful PFS benefit by blinded independent control central review versus THP, which was consistent across subgroups. So hazard ratio of 0.56, which is statistically significant, and median duration of response also was significantly higher, and complete response rates were 15 versus 8.5%. So early OS data suggest a positive trend in favor of TDXD plus P and a supportive hazard ratio of 0.6 for PFS2. So TDXD plus P safety also was consistent with the known profiles of individual treatments. Next slide. So when we see the evolution of the treatment in HER2 positive advanced metastatic breast cancer, so the standard of care is Cleopatra in this setting, so which gives a median PFS of 18.5 months. So however, TDXD plus P in this study, we see almost 40 to 44 months. So if we employ TDXD in second line, when compared with TDM1, it showed 28 months in addition, and in third line 17.8 months in comparison with treatment of physician's choice. So should we, based on this trial, though the overall survival is yet not mature, consider TDXD plus P in the first setting. Next slide. So in when actually almost 50% of the patients in this study are hormone positive. So when we consider Patina trial, like which is almost an extension of Cleopatra trial, so in that setting, the PFS is 44 versus 29 months. So I mean, in hormone positive, if we consider THP, the PFS is almost reaching to that of this study. And second question is CNS protection is not explored properly here because the number of patients with brain mets were relatively less. Next slide. So this is again the response rates. Clinical benefit ratio was 85 versus 78.1, 15 versus 8.5 months complete response rates, and median duration of response also was significant, 39 versus 26.4. Stable disease. Next slide. So the sequencing for PFS benefit is important. Is this a first-line option for positive metastatic breast cancer based on clinically significant PFS? So the ideal sequencing strategy, if the patient is HER2 positive, hormone receptor positive, should we consider Cleopatra, that is THP upfront, followed by palbociclib addition and maintenance with trastuzumab and pertuzumab, and DB3, that is TDXD on recurrence or progression of the disease. So in that setting, we get a PFS of almost 73 months. But this is assuming that all the patients go on to receive second and third line subsequently, which doesn't happen usually because majority of the patients drop out from one line to another. So almost 30 to 40% drop during second line, and similarly 30% of patients drop the third line. So the other option in HER2 positive, HR negative patients, probably with Cleopatra and DB3, we get a combination of around 18 plus. So almost 56 months we get benefit in HER2 positive, hormone receptor negative patients, and 67% of the patients had trastuzumab pertuzumab in the DB3, I mean in the Cleopatra, following which the DB3 was employed. So when we combine 18 plus 29 months, that is 56 months. So this is assuming that all the patients go on to receive second line. Next slide. So this is the Patina study trial design. So similarly, same thing, hormone positive, HER2 positive metastatic breast cancer were randomized to palbociclib with trastuzumab pertu versus trastuzumab pertuzumab along with endocrine alone. So next slide. So here we can see 44% versus 33.4%, that is 44 versus 29% in terms of median PFS, comparing palbo arm in addition to anti-HER2 and endocrine therapy versus placebo arm. So we are getting significant PFS benefit here. Here again, OS is still immature, and we don't know if we would get OS benefit here. Next slide. So the pros are that of DB09 study is that there are less line-to-line attritions. So even though the majority of the patients may not go on to second, third line, they would get benefit with the first line option. CNS failures are less, but this question is yet unanswered in this particular setting. And the cons are toxicity, activity of HER2 climb post DB09, because when we are thinking of sequencing, how to add tucatinib down the line and all, so that question still remains. So we don't know the CNS protective effects of this. Next slide. So PFS2 also has been explored in this study, and as of now, the hazard ratio is 0.6, not yet fully matured. Data maturity is only 20 to 30%. Still, there is benefit, but we have to see in the long run. So this is despite 10% of the patients in the THP arm when going on to receive TDXD. So majority of the patients from THP, at least significant number of patients go on to receive the second line TDXD. So despite that, we got a significant PFS2 benefit in this study. Though which is not yet mature. Next slide. So OS is only at 16% maturity, but the trend is favoring the experimental arm, that is TDXD plus P. Next slide. So when we see the treatment emergent adverse events, majority of the treatment discontinuations were in the chemo arm. However, dose interruptions, inductions were in the experimental arm, and even there was a small number of treatment emergent deaths in the TDXD plus P arm, that is around 3.4% compared to 0.8%. So this is one event is due to ILD and one event due to heart failure. So this is notable, but it's not significant. Next slide. So to come, at this DCO, there is clear-cut benefit in terms of PFS and a trend in favor of OS and PFS2. Next slide. So again, treatment related adverse events. are relatively comparable, more or less. Next slide. So this is to highlight the important grade 3 events, that is neutropenia, fatigue, and elevation of liver enzymes, which are relatively higher in TDXD arm, but neutropenia is higher in the chemo arm. And so the grade 3 events were comparable. However, only 0.3% grade 4 and 5 events were there. Next slide. So again, similarly, adverse events of special interest, ILD and pneumonitis, and left ventricular dysfunction, which I already mentioned. Next slide. So the key takeaways are: so is this a first-line option, and is it going to replace the Cleopatra THP regimen? Based on PFS data, yes. But again, when we consider sequencing, and if we assume all patients won't be receiving third lines, probably Cleopatra scores, especially in hormone receptor positive, where we consider addition of palbociclib down the line. But in hormone receptor negative, definitely this benefits. So the sequencing strategy, if we see, we probably have to further refine to adapt this. Next slide. So CNS protective effect, we don't know yet. Is PFS2 likely to be impacted by TDXD post progression? Yes, because 10% got TDXD, and the contribution of pertuzumab we don't know yet, because that is still blinded, and it will be analyzed at data full maturity. And is toxicity a concern? Yes. Would discontinuation of TDXD at some point be an option? Maybe, but not as of now. And there are no clinical or lab biomarkers information as of now. Next slide. So the second study we are going to see is sacituzumab govitecan plus pembro versus chemo plus pembro in patients previously untreated PD-L1 positive, advanced or metastatic TNBC, SN4 or Keynote D19 study. Next slide. So this PD-L1 positive TNBC metastatic patients, it's like there is an unmet need, because the PFS with first line is only 7.5 to 9.7 months, and sacituzumab govitecan is top directed ADC, which demonstrated overall survival benefit in multiple studies, and is approved for second line triple negative breast cancer with metastasis. Slide. Next slide, please. So here basically immunotherapy along with sacituzumab versus chemo was studied. Next slide. So results from SN4 study support the use of sacituzumab pembrolizumab as a potential new standard of care of patients with a median PFS of 11.2 versus 7.8 months with a hazard of 0.65, which is statistically significant. And overall response rates also were higher and more durable in sacituzumab arm. Next slide. So the key takeaways are the combination of sacituzumab with immunotherapy led to a statistically significant and clinically meaningful improvement in PFS versus chemo plus pembrolizumab. Next slide. So the progression-free survival, which I already mentioned, 11.2 was 7.8 months, which is statistically significant, and you can see that the curves are clearly separated. Next slide. So again, this is all the statistical analysis. Next slide. So demographics more or less balanced between the arms. Next slide. So when we see subgroup analysis across all arms, whether it's 65, more than 65 performance indicators, then whether taxane or gemcitabine carboplatin was employed, and higher treatments. So the number of patients, number of patients is less. If prior treatments were received, did not benefit. So this is not significant. Next slide. So OS, as of now, 81% of patients who received, actually in this study, they allowed the crossover to sacituzumab govitecan upon progression in the chemo plus pembro arm. So almost 81 patients 80% of patients went on to receive sacituzumab botican. So despite that, we got a significant PFS. So when we account this crossover, when we account statistically the crossover, the overall survival would benefit sacituzumab botican. So that has to be and at maturity of 26%, there is a positive trend in favor of sacituzumab plus pembro arm. Next slide. So it was found that sequencing one ADC following another ADC should not show much benefit. Only 3.5 versus 2.5 patients who first went on ADC followed by sacituzumab versus sacituzumab followed by DXD. The magnitude of benefit was quite low. Next slide. So again, median duration of response was 16.5 versus 9.2 months, which is statistically significant. Next slide. So when we see versions, it is also, comparable between the two. Same neutropenia, fatigue, diarrhea, nausea, etc. Next slide. Next slide. So is SN4 an option for first line in MBC patients? Yes, we should consider in first line because PFS benefit is significant, lesser progression of disease in the sacituzumab arm, and most of the patients, 50% of patients may not go to second line, and patients who relapse after 522, we are not sure because after failure of immunotherapy whether ADCs benefit. Next slide. So is the crossover to SG likely to blunt OS? Yes. Sequencing, what do you do after SG pembro? So we can consider chemo and targeted therapies, and ADC after ADC, very limited activity, and top 2 expression biomarker analysis is not available. Next slide. So the other study which was discussed was NeoCAR HP. So it is to de-escalation. So whether to in the combination of taxane plus trastuzumab and pertuzumab, whether addition of carboplatin if we exclude carboplatin, do we get the similar benefit in HER2 positive early breast cancer? Next slide. So NeoCAR HP aimed to evaluate the safety and efficacy of de-escalated neoadjuvant taxane plus trastuzumab and pertuzumab with or without carboplatin in early breast cancer, HER2 positive. Next slide. So it's a multi-center open label phase trial. THP 6 cycles every 3 weekly. What is THP plus carboplatin? Next slide. So T1, T2 patients were the majority patients, 80% in the study. T3, T4, 18 to 20% of the patients. So stage 2 with most of the patients, and nodal status was positive in 64%. When we see the taxane therapy, paclitaxel 44%, docetaxel 35%, paclitaxel 19%. So overall response we see it is between both. So despite not including carboplatin, there is not much in terms of response rates, whether in hormone positive, hormone negative. Next slide. Next. So putting it across various trial results in context, in NeoCAR HPTC 66%, PCR overall, in ER positive 59%, and ER negative 70%. So Trifina 64%, that's response, and in ER it was 84%. In train 2 TCHP 96 also it was 84% in PCR in ER negative and about 55% in ER positive patients. Next. So in Helen, where nab-paclitaxel was combined with trastuzumab and pertuzumab, also it was around 66% PCR was achieved. Next slide. So even NCCN guidelines have allowed TCHP as well as TCH and paclitaxel plus trastuzumab as well. Next slide. So when we see majority of the patients who benefited were stage 2 patients, and nab-paclitaxel patients had higher benefit. Next slide. So safety wise, increased grade 3 adverse events in TCHP arm were neutropenia 16.4% versus 6.8, febrile neutropenia 2.6 versus 1.3, thrombocytopenia 4.2 versus 0.3, and anemia. So higher overall, higher all grade nausea, vomiting, and increased creatinine. So by adding carboplatin, probably we are adding only toxicity and we are not getting any additional benefit. Next slide. So the key takeaways are: can we omit carboplatin from standard neoadjuvant therapy? Yes, stage 1 or 2 disease. But weekly paclitaxel is found to be having the strongest evidence, and long-term outcomes and biomarker data are still awaited. 4 cycles of treatment with THP, is it sufficient for stage 1, 2 disease? Next slide. Weekly paclitaxel, because of the data from Helen trial, which shows that it is comparable and superior. From the Helen trial, not from this trial alone.
Sir,
Uh,
I'm
is it
so
possible
sorry
to?
hello. I'm so
Yeah,
sorry to interrupt, sir, but can we like wrap up in a few minutes? We're just short on time.
yeah, in 3-4 minutes.
Sure, sir. Okay.
So is it possible to omit standard chemotherapy for some patients? Not quite yet, until we have validated ways to predict patients. Do patients with PCR after chemo-free or ADC therapy need adjuvant chemo? Maybe not, though prospective data is needed. And can biomarkers be used to right side therapy? We are getting really close. Next slide. So this is again safety. So obviously carboplatin arm has higher incidence of thrombocytopenia, neutropenia, etc. Next slide. So the last study would be web-based restraint, which is a PROTAC degrader versus fulvestrant in ER positive, HER2 negative advanced breast cancer from VERITAC 2 phase 3 study. So basically, PROTAC ER degrader acts differently by using the ubiquitin protease system, wherein it degrades the estrogen receptor rather than blocking it. Next slide. And its oral form, in contrast to fulvestrant, which is not soluble, so hence it has to be an IM, intramuscular administration. Next slide. So it is the first PROTAC to be evaluated in a phase 3 study, and oral vepdegestrant was well tolerated and demonstrated statistically significant and clinically meaningful improvement in PFS when compared to fulvestrant in patients with ESR1 mutation. So this results of this VERITAC 2 study support vepdegestrant as a potential treatment option for previously treated ESR1 mutated, ER positive, HER2 negative advanced breast cancer. Next slide. So this is the mechanism of action. Mainly, it depends on the ubiquitin system to destroy the ER, to cause the ER degradation. Next slide. So patients who progressed on prior endocrine therapy with or without CDK4/6 inhibitors, majority of the patients received CDK4/6 inhibitor in the study were randomized to vepdegestrant 200 mg oral once daily versus fulvestrant 500 mg day 115 first cycle followed by 500 mg monthly. So PFS was the primary endpoint and it was mainly stratified in ESR1 mutation, based on ESR1 mutation and viral disease. Yes or no? Next. So in this study, around 43% of patients had ESR1 mutation, and almost all the patients were received prior CDK4/6 inhibitor and 1 or 2 lines of prior endocrine therapy. Next slide. So the median follow-up was 7.4 months. Median PFS was statistically significant, the 5 months versus 2.1 months, especially in the ESR1 mutated arm. This is the ESR1 mutated arm patients where it is 5 versus 2.1, which is significant. Next slide. So in the other overall population, there was no significance, and second endpoint OS was immature. And next slide. Clinical benefit ratio and ORR were also higher, significantly higher in ESR mutated patients. Next slide. So the tolerability, grade 3 events were 23% versus 18%. Treatment discontinuations were negligible and not much adverse events. Next slide. Thank you.
Thank
Yeah,
you for this
yeah,
informative session, Dr. Venkat.
yeah. Thank
Yeah.
you, sir. So that was a great elaborative presentation. But we have some time constraints, but that's okay. I'll just be talking about 2-3 things about we have DB09 role of TDXD pertuzumab. Pertuzumab contribution itself is really questionable because we don't have the TDXD plus placebo arm readout. That's one thing. Second thing is TDXD definitely ILD pneumonitis 15% close to. So that is obviously a concern as of now. And we would like to definitely wait for data to mature for OS. Uh, uh, I think you also agree with that. So as of now, we are all comfortable with doing Cleopatra in the
Yeah.
front line. Yeah, and as you rightly pointed out, yes, Patina, wherever they are triple positive, ER, PR, HER2 positive, definitely after 6 cycles of THP induction, we would like to add palbociclib endocrine therapy for dual HER2 maintenance. Yeah, I think with that, we'll move to the next session. Yeah, thank you.
So with this, I would like to invite Dr. Rekha Bansal. She's a consultant medical oncologist, Apollo Hospitals, Hyderabad, to take this forward. Welcome, ma'am.
Hi, everyone. Good evening. Thank you, Venugopal sir, for giving the opportunity, and thank you, AstraZeneca. So I think my screen was visible, right? And okay, please allow me to share my screen now.
Your screen is visible, ma'am.
All right, thank you. Sorry about the delay. So we'll talk about DB06, though this was not presented in 2025, only in ESMO May 2025, the patient-related reported outcomes were presented, and already this is approved, Enhertu. So Enhertu, it being the blockbuster molecule, we have the DB04 data, which based on DB04 and DB06, we got the approval for use of Enhertu in HR positive, HER2 low MBCs. So let's look at the DB6 data today. No, these are the outlines of the talk. We'll quickly go on to the discussion per se. So any metastatic breast cancer could probably be divided into these. So about 15 to 20% would be HER2 positive, about 65% would be HR positive and the conventional HER2 negative, and about 15% would be TNBC. But when you further break down these HR positive, HER2 negative, then you come up with three more subsets. That is HER2 low, HER2 ultra low, or actual HER2 negative. So HER2 low by themselves constitute about 60 to 65% of the overall HR positive, HER2 negative population, which is quite a chunk. And then we also have ultra low. Now let's briefly look at what this really means. So until now we were treating HER2 as a binary thing, either positive or negative. But now we are talking of it like a spectrum. So IHC 0, it's no brainer. It means total absence of HER2 expression. But when we look at ultra low means that less than 20% of the tumor cells express faint or incomplete staining. These also constitute about 1/4 of these patients, that is HR positive, HER2 negative patients. And when we talk about the HER2 low, it could be 1 plus or 2 plus. 1 plus is more than 10% of the cells, but faint and incomplete staining. And HER2 2 plus is actually more than 10%, but strong staining, you could say, moderate staining. So why was even, I mean, it's kind of a mind-blogging thing, you never thought. For us, always anti-HER2 therapy was in HER2 positive patients. We never even imagined that HER2 negative patients could also benefit from it. So DB04 already kind of gave us that option in the third line. So let me just tell you a few differences between DB04 and 06. 04 was after prior endocrine and prior chemotherapy. It included HR negative population also. And it didn't include ultra low HER2. So basically in HR positive MBCs, after CDK4/6 inhibitors and few targeted therapies now which we have, though all the time we say it's crowded space, we don't really have much to offer. And like Sampath sir was mentioning, from first line to third line, there is almost an attrition of close to 20% after every line. So we might achieve, PFS of about 2 years, 2.5 years with CDK4/6 in this subgroup, in this MBC set of patients. And with the second line and targeted therapies, again, about 2 to 5 months. And if we reserve PDXT for the third line, a PFS of 10 months. But why wait till here when we have such attrition? That is what the idea of DB6 was, to move Enhertu to a earlier line of therapy. So we are all well aware of TDXT. It's a ADC. The ratio of drug to antibody is 8:1. It has a cleavable linker. We all know how there is internalization, then the payload is released, and the payload acts on the HER2 negative cells also. That's the whole idea. That is, these set of patients, that is low and ultra low, would have a heterogeneous expression of HER2, and thereby even the neighboring cell, which would not have HER2 expression, would also undergo cytotoxic kill. So let's look at the study per se. It's an open label randomized multicenter phase 3 study. HR positive, of course, were included, low and ultra low patients. Chemotherapy naive. So this was the major difference between 4 and 6. When we say prior lines of
we are not able to see your slides, Dr. Rekha.
Oh,
Are
so
you-
sorry. I moving them actually. So shall I stop and share again?
Yeah.
Uh,
Or-
You share the entire screen.
yeah, I'm sharing the entire screen. I'm so sorry. So it just says that the screen sharing has stopped. Yeah, I'm so sorry.
Yeah, now we are able to see your slides.
Okay, sir. So we were talking about the patient population in the DB6, sir. So
Yeah, till
prior
now,
lines.
that's fine. Yeah.
Okay, sir. So prior lines of therapy, what were the prior lines allowed? Patients should have received at least 2 lines of ET in MBC setting, or the endocrine refractory patients, that is patients who had progressed within 6 months after starting first line CDK, or patients who had progressed within 2 years of adjuvant endocrine therapy, were randomized 1:1 to receive either TDXT at the MBC dose, that is 5.4, versus the treatment of physician's choice. Now, surprisingly, these are the same exact chemo which were actually used in DB4 also, though it was a later line. So I don't know how to explain that. And the primary endpoint was independent assessed PFS in HER2 low. So probably based on DB4, they wanted to probably first look at how HER2 low will respond. Of course, they in the intent to treat population, they also included the assessment of ultra low. And there were secondary endpoints. Secondary endpoints were OS in HER2 low, OS in intent to treat population, and certain other exploratory secondary endpoints. Key stratification factors were prior CDK4 use, extent of HER2 expression, and whether use of taxane in the prior treatment affected the outcomes. So if we see the baseline characteristics, let's restrict to first intent to treat population here.
No,
Good
again, we are not seeing your slide deck, Rekha. We are just yeah. So now currently we are able to see the slide showing Destiny Breast 06 background and study design. That's what it is stuck. After that.
Okay, I don't know why they're not moving.
Yeah. So otherwise, can you share Havni from your end, because or it takes time.
One last time I'll try, sir.
Yeah. Now can you just scroll it down? Otherwise, you can try, Rekha. Yeah.
Is it seen now, sir?
Yeah, it is seen, but after this,
Slideshow.
can you just yeah, I think this should be okay.
Thank you so much, sir. So we were talking about the baseline characteristics in the intent to treat population, good representation of Asian population, almost 35%. So whether ethnicity or regional, there was representation, global representation is what I could say, and ECOG performance 0 to 1 were included. What about the IHC expression? So ultra low constituted about 17% of the population in either arm. 1 plus were about 54%, and 2 plus were about 26% patients. Most of the patients had strong, HR positivity, both ER and PR positive, about 60%. 30% patients were primarily endocrine resistant. 30% patients were stage 4 at diagnosis. There was representation of visceral disease also, almost 86% patients, and 67% patients, 65% patients had liver metastasis too. They also included patients with brain metastasis, about 8% of the patients. Then number of looking at the prior lines of therapy, like we discussed, of course, at least 2 lines of endocrine therapy was the limit. Refractory patients, again, about 8.5% patients had refractory disease to CDK4/6 inhibitors, and patients had received either fulvestrant as part of their endocrine therapy or with CDK4/6 inhibitors. Now let's talk about the efficacy and the safety. So coming to the PFS in the primary endpoint, that is HER2 low only, not the ultra low. So independent assessment, definitely there was a benefit of the median PFS, 13.2 months versus 8.1, delta of 5. Hazard ratio is 0.6. This is statistically significant. And coming to the intent to treat population, including both ultra low and low, again, because a major chunk of the patients were low, don't know whether this is being driven by the low population only, but there was statistically significant PFS benefit. Now, looking at the OS benefit in HER2 low and intent to treat population, this is only 40% maturity. So numerically, definitely you see that there is benefit, but although the hazard ratios are 0.8 and the confidence intervals are crossing 1, this could be because of the crossover that was allowed in the trial.
Ma'am, sorry to interrupt, but I think your slides are still not moving.
All right, you can share them. Yeah, thank you. So you can come to the subgroup. You can come to the slide number. Yeah.
Is my screen visible? Hello.
Yeah, visible.
Ma'am, is this the slide you require right now?
I'm not able to see the slides.
Okay.
Okay, yeah. Now I'm able to see. Yeah, please. Next slide, please. Next slide, please. Next slide. Next slide. Yes, so OS in HER2 low and intent to treat at 40% maturity, hazard ratios are 0.8. Now, we'll have to see whether these keep separating or whether this benefit is maintained. Next slide, please. In the pre-specified subgroups, the HER2 expression does not seem to really impact the effect. Of course, the hazard ratio in HER2 1 plus is 0.7, and the confidence interval is almost reaching unity. Prior use of taxane does not seem to affect. Prior use of CDK4/6 inhibitor does not seem to affect. Next slide, please. What about the ultra low? Like I was saying, if this is a pre-specified exploratory analysis. Again, the benefit seems to be maintained, but the confidence intervals are crossing unity. Next slide, please. What about the overall response rate? So you could say that definitely there's almost doubling of the response rate in intent to treat population and HER2 low. And if you were to purely look at response rates, even the ultra low, she seems to be showing overall response rate. The best responses were mostly the partial responses across the board, and the duration of responses are also almost doubling. Next slide, please. What about the endocrine refractory patients? So whether the patients who had progressed on CDK4/6 inhibitors within 6 months, in 1 year, or more than 1 year, they all seem to benefit. Next slide. And again, PFS2. So PFS2 in the intent to treat population, though there was a crossover, there is definitely PFS2 advantage. Trying to hint is that it could probably have a residual durable effect beyond progression. Next slide, please. What about the disease burden? The number of metastatic sites did not affect the quantum of benefit or the benefit. There seems to be a benefit regardless of the number of the sites. Next slide. What about the safety? So we all know that. Next slide. Yeah, we all know that the pneumonitis is a major risk to watch out for. So let's break this down. And the most common adverse event leading to discontinuation was pneumonitis in TDXT arm, 5.3%, and in the standard chemotherapy arm, it was the neuropathy, which led to discontinuation in 1.4% patient. Those reductions were happening in TDXT arm mostly due to nausea and treatment-related deaths. If you see, treatment-related deaths were actually reported in the TDXT arm. Next slide, please. So exposure adjusted incidence rate. So like we said that the median duration of treatment was almost double in TDXT. So was longer treatment effect, associated with higher incidence of adverse events? So when we try to look at this, and as far as I understand, this is showing that despite longer exposure, the side effects seem to be more with the chemotherapy arm only when compared to Enhertu. Next slide, please. We are all aware of the toxicity profile of TDXT, more of nausea. It's highly emetogenic. It causes fatigue, alopecia, and obviously these numbers were more in the experimental arm when compared to the chemotherapy arm. Next slide, please. Now, this is, I think, of interest. That is ILD and pneumonitis. So most of them were grade 1 and grade 2 in the TDXT arm. And left ventricular dysfunction, again, it could be either in the form of ejection fraction reduction or cardiac failure. Cardiac failure were not reported in TDXT, probably only in the chemotherapy arm they were reported. Ejection fraction decrease, again, most of them were of grade 1, grade 2 only. The time to watch for ILD is about, I think, 4 to 5 months. That is the median time where ILD symptoms develop. That is the median time. So that is when to watch for it. Next slide, please. What about the quality of life? So this shows that from the baseline, there was not much different. Though the patients received Enhertu for a longer period of time, despite that, the overall health-related quality of life was similar as the chemotherapy arm. Next slide. So conclusions, definitely TDXT has proven to have a statistically significant and clinically meaningful PFS benefit when compared to the chemotherapy arm in this HR positive, HER2 low and ultra low population, with doubling of response rates and no new safety signals being identified. Next slide. What about how to manage the pneumonitis? Next slide. So one thing is, because it's a emetogenic drug, a 3-drug anti-emetic protocol should be followed. I don't know why it says no steroid should be administered, because all the of the protocols that we use for highly emetogenic, they include dexamethasone for 3 days, day 2 and day 3. But here it says no steroid should be administered after day 1 of Enhertu. Next slide, please. So again, this is just real world data, one from Japan, one from Italy, trying to say that 3-drug anti-emetic regimen is better than 2-drug. I think we all agree. And whenever we use this medicine, I'm sure we'll all resort to using a 3-drug anti-emetic regimen. Next slide. So symptoms of ILD to watch for: cough, dyspnea, fever, and any respiratory symptom. Next slide. So how to manage grade 2, grade 3, obviously we will discontinue Enhertu. For grade 1, again, if it is resolving in within 4 weeks, then we can continue to give the same dose. If it is resolving beyond 1 month, then we have to resort to one level reduction. And if it is prolonged beyond 18 weeks, then we have to discontinue Enhertu even for a grade 1. And sometimes we might have to use steroids to manage this pneumonitis. Next slide. Again, once the patient is diagnosed, we will obviously follow the patient up and continue to perform imaging to make sure that it's resolving. Next slide. So one is to let the patient know what are the symptoms of pneumonitis. Another thing is we per se, before every infusion, we have to ask the symptoms of pneumonitis and HRCT to be performed, PFT to be performed every 3 to 4 months duration. Next slide. So it's already, next slide, please. It's already part of the guidelines with this benefit. I think the approval came in January 2025. FDA has approved for HR positive HER2 low population. Next slide. These are the ESMO guidelines showing it already TDXT part of this. Of course, we do have sacituzumab and datopotamab, but I think that discussion can be for some other day. Next slide, please. That's it. Yeah, NCCN also has it as part of the guidelines. Next slide. I think that is the end of the talk. Yeah. Thank you.
Yeah, Dr. Rekha, very good, nice talk. So basically, I have 2 questions for you, real-time challenges. So do you feel challenges even now, standardization or validation of low, ultra-low reportings on a day-to-day clinical practice? Yeah, what is your thought on that?
Pathologists are also learning, and the companion diagnostic which is approved is something called pathway antenna assay, but I'm sure we don't have it, and we are using whatever is available. So it's all a learning curve for all of us.
Yeah. And one more thing, are you happy for the subgroup of patients with ultra low group of patients also, too, ultra low?
No, sir, maybe not. Yes, sir.
Yeah. And as we were discussing, DB04 has included HER2 low previously treated 1-2 lines, and DB06 shifting it to the prior
Yes,
earlier.
sir.
Yeah.
Yes, sir.
I think with that, thank you. With that, we'll move to.
Thank you, sir.
Yeah. Yeah, Avni.
Dr. Venugopal, should I start? This is Dr. Rakesh here.
Yeah, Dr. Rakesh. So we'll go to the next session, redefining standards, optimizing first line HR positive, HER2 negative ABC with CDK4/6 inhibitors. So I would like to invite Dr. Rakesh for the session to be conducted. Yeah, thank you.
Hi, good evening to all. Thank you, Dr. Venugopal, for this platform and Novartis for this opportunity. So, do I have my panelists, Dr. Vindhya? I can see her, Dr. Sanath and Dr. Shikhar. All are there?
Yes,
sir. Yeah, welcome everybody. We are going to understand how the first line management of hormone receptor positive and HER2 negative advanced breast cancer is there, with a specific focus on CDK4/6 inhibitors in a routine clinical practice. This is not a case-based panel discussion. This is something of a general review of the guidelines and the rationalizing the utility of CDK inhibitors in the frontline management of basically metastatic hormone receptor positive advanced breast cancers. If you look at the complexities of frontline clinical decision making, we have to take into consideration both patient-related factors as well as disease-related factors. And ultimate goal is to improve and prolong the survival, however, not to impact the quality of life, so that the aspirations and expectations of the patients are continued to meet it. So basically, the disease-related characteristics include the clinically aggressiveness of the disease, presence of disease in the visceral sites, and clinical catastrophe, eminent clinical catastrophe that can make a difference between whether we use chemotherapy or CDK inhibitors and hormonal therapy. And as of now, even in that conditions, we are going to prefer more so in the hormonal therapy. So this is the current guideline schema. This is from the ESMO, and again, the ESMO as of today, it has given in a flow chart in which if there is an eminent organ failure, chemotherapy is preferred even in a hormone receptor positive and HER2 negative metastatic breast cancer. However, in those patients without such requirements, endocrine therapy is the de facto standard of care, and the endocrine therapy is the combination of CDK inhibitors plus either fulvestrant or with the letrozole or anastrozole. And at the time of disease progression, patient can be go on to something that can be targeting a specific mutations like PIK3CA mutations. We can use the fulvestrant and alpelisib, or germline BRCA or PALB mutations. We can use PARP inhibitors, olaparib. So somebody who doesn't have any of these mutations can go on to receive second-line endocrine therapy, which could be a single agent fulvestrant, or a combination of everolimus plus exemestane or everolimus plus fulvestrant. Both Bellarov and SOLAR trials have alluded to the benefits with respect to PFS. Ultimately, patients will go on to receive chemotherapy at some point of time. At this point in time, I would like to also add that for those patients, continuation from the previous talk from Dr. Rekha, if the patient is having a HER2 1 plus or 2 plus, based upon the Destiny trials, Destiny Breast 06 trial, we can also use a second line utility of the antibody drug conjugate of Enhertu in the subsequent line therapy who have at least exposed to one line of endocrine therapy. So this is the current standard of care in the frontline utility of advanced breast cancer. CDK inhibitors in combination with the AI has shown overall survival benefit with respect to Mona Lisa 2 trial. The ASCO has clearly put down that a median overall survival benefit of at least 20% would be clinically meaningful for patients who are having hormone receptor positive advanced breast cancers. With that regard, we can see clearly out of the 3 clinical trials, the Mona Lisa 2, Polamod 2, and Monarch 3, all of them in the frontline setting, we can see the hazard ratio 0.76 and the confidence intervals falling well within the significance. And it is the only Mona Lisa 2 trial that has shown very conclusively the overall survival benefit in these patients. Let's look at the goals of treatment for advanced breast cancers. This is the advanced breast cancer clinical guidelines, where there are very clear comments saying that we need to aim for a treatment that has not only the ability to add quantity to the life, but also the ability to preserve the quality of life. And hopefully the patient perspective is also met, which is again to maintain a quality of life at the same time prolonging the life. So let's look at that in the backdrop. Again, let me bring in our panelist, Dr. Vindhya Madam. Based upon the evidence that is out there, what is your thoughts on PFS being a surrogate for overall survival? And would you consider that PFS would always translate to OS, especially in a disease like hormone receptor positive, where there is enough time to re-intervene again? Dr. Vindhya.
Yeah, especially seeing the Mona Lisa trial result, PFS, though there is PFS benefit with all the 3 CDK4/6 inhibitors, only ribociclib has shown an OS benefit. So, especially in the case of CDK4/6 inhibitors, at least PFS would not translate into an OS benefit for all. So we have seen OS benefit only for ribociclib, though most of these patients. After progression on first line CDK4/6, they went ahead to receive fulvestrant or exemestane, everolimus or chemotherapy. But the OS benefit was seen only with ribociclib. So taking PFS benefit alone as a surrogate marker wouldn't be judicious in these patients who have definitely had benefit with ribociclib compared to other CDK4/6 inhibitors.
Yeah, I think I get your point, and you are trying to focus on treatments that have absolute OS benefit. But let me bring in Dr. Shikhar. What are the fallacies, Dr. Shikhar, regarding looking at PFS? Because all the 3 trials have similar PFS benefits, and if you have only that particular data, what are the biases that you actually get into when you only look at PFS and overall response rates?
I mean, sir, if the PFS benefit is equal between the 3 drugs, the 3 CDK4 inhibitors, that makes my choices very clear. That's what I tell the patients, that see what the trials set out to achieve as the primary endpoint, all the 3 trials did achieve it. So explaining a concept to our patients regarding second line, third line treatments, and the palbociclib trials having excessive dropouts and thereby impacting OS is something which is very difficult to explain to even the most educated of patients. So I think PFS and like Vindhya madam clearly rightly told that PFS is it's a poor surrogate for OS, especially in an indolent disease like HR positive MBC. So keeping all these things in mind, I think I am quite satisfied with PFS as the endpoint which was used in these trials. It is not practical to use the OS as an endpoint because of the time duration that would be required to complete these trials and to bring these treatments to our patients. And I am quite satisfied with the PFS data alone. I would not really, dwell too much on the difference in the OS outcomes between the three different CDK4 inhibitors.
Interesting. So again, this is a different varied views that we get across when we actually put down the science of it in the clinical practice. So let me bring in Dr. Sanath again. The PFS OS debate is going to happen anyway. That is an endless debate that is going to happen with every other domain of solid tumor malignancies treatment that we do. How is quality of life important for you? Because this is a treatment that may go on for years together. And the the irritations that the drugs have can accumulate over a period of time. So are you going to look at quality of life secondary outcomes very closely, or you are going to say that once the disease is under control, you are going to get quality of life anyway? What is your perspective with respect to these oral drugs and quality of life?
Sir, definitely quality of life matters, sir. And with three CDK4/6 inhibitors, abemaciclib has poor quality of life because of more side effects. And though palbociclib we are using from many days, it has paper toxicity of neutropenia, which is very common. So it can cause anxiousness in the patients. And ribociclib, I think, well managed. Though hepatotoxicity, prolonged QT intervals are there, still I have 4 to 5 patients on ribociclib. I did not see any prolonged QT interval. Hepatotoxicity also I did not see. I saw initial fatigue which are there with ribociclib. So, see quality of life, Avima has lowest, and Palbo and Ribo both are equal. And regarding the previous discussion, if you see, not only overall survival, sir, if you see response rates, CNS penetration, activity in the adjuvant setting, activity in the visceral disease, so these all are better with Ribo when compared to other CDK4/6 inhibitors. So this also we have to keep in mind. And statistic.
I think we are losing you, Dr. Sanath, and we are not able to hear you, but you made this real valid points with respect to the utility of ribociclib in frontline setting. I think some of your points are reiterated in this slide as well. We know that CDK inhibitors have a significant effect in the frontline management of hormone receptor positive breast cancers. CDK inhibitors, especially the CDK4s and for CDK6, both are responsible for cell proliferation and tumor growth. And in breast cancer, it is the CDK4 that is much more dominant compared to that of CDK6. Again, CDK4 levels are upregulated nearly 8 times more than the CDK6 in breast cancer cell lines. And if you look at the differences of on-target and off-target binding capacity of individual drugs, we can clearly see that ribociclib and abemaciclib are much more potent compared to that of the palbociclib. And abemaciclib appears to be having a multitude of effects, mostly off-target effects, because of its activity against CDK1 to CDK9 kinases. So with this respect, we can expect to have a lot many off-target effects with the abemaciclib. So let me bring in Dr. Shikar again. So if a drug is having similar PFS and we have 3 options and we have similar PFS across the 3 options. And if one of the drug has a better quality of life, one of the drug has better overall survival, you would obviously gravitate towards that better treatment, isn't it?
The quality of life also depends a lot on the kind of supportive care the patient receives, not just the drug alone, and the dose, the starting dose of what we choose. Like say, for example, now I'm sure many of our patients, they don't tolerate palbociclib 125 mg full dose well. and we are very comfortable in reducing dose to 175 mg -1 -2 level. Same way, now we have enough data from even ribociclib trials, even Natalie trial intentionally chose a lower starting dose of 400 milligrams. So choosing the right dose and managing the symptoms aggressively, giving good antiemetic prophylaxis along with, because we know all the CDK4 inhibitors, they do cause a lot of nausea. That matters more. And don't think there is any head-to-head data saying that one drug has better quality of life than the other. But I think it's the dose which matters more, and the way we manage the symptoms that really makes the difference.
Yeah, I think we need to be very vigilant that despite this being a oral drug, it requires a lot much of tinkering of the doses and lot many counseling happens in the initial months that would set the ball rolling for the rest of the the treatment plan. So we have known that these drugs are pharmacologically different. There is a different off-target or on-target activity of individual drugs. We know that they have a different steady state concentration with respect to the bioavailability within in vitro situation. Again, the free drug exposure, which is normalized to palbociclib, again, free drug steady state, AUC undercurve, everything looks like the ribociclib dosing achieves a much more stronger dosing for clinically relevant dosing that we apply in our patients in the metastatic setting. So based upon this evidence, Dr. Vindhya, what are your thoughts on differences in efficacy and safety outcomes with all the three CDK4 inhibitors? Looking at this steady state concentrations, looking at the overall binding characteristics of CDK inhibitors, which of the three drugs which you feel would probably be more efficacious with less amount of side effects?
I think ribociclib, especially because it has more selective affinity for the CDK4 compared to the 6 and other CDKs, it has more efficacy to side effect, better efficacy to side effect profile compared to the other two. Though palbociclib, yes, we are very comfortable with palbociclib. We haven't seen um, uh, very discomforting toxicities with palbo, but the efficacy is likewise low. Compared to abemaciclib, ribociclib is very well tolerated, and now even we most of the patients we put them on 400 mg if they're not tolerating, and the efficacy is not affected. Abemaciclib somehow, though they say that the hematological toxicities are low, but most of my patients they end up with severe anemias and thrombocytopenias requiring dose interruptions, dose reductions, or stoppage of the drug or change over to ribociclib even. So I think of the three, ribociclib is the most effective and well tolerated CDK4 by 6 inhibitor.
Yeah, Dr. Shikhar, again with you. I think this is the NCCN guidelines from 2024, and we can clearly see that despite the other endocrine partner being either anastrozole inhibitor, anastrozole or letrozole or fulvestrant, ribociclib appears to be have a category 1 recommendation across the board. So how important is this for you? What is the usual practice of combining the endocrine partner with CDK inhibitors, and the ability to use either one of them? Is it important for you, or you're sold with one combination?
So I think there are two parts to the question, sir. One is the how important is the NCCN category and the ESMO MCBS score in choosing which CDK4 to go for.
Or let me say,
Obviously,
which is the usual practice for you? And let's start with that, and your ability
so
to.
it boils down to the patient's the financial status and the patient's literacy status, because now patients they read up all the guidelines and evidence, and there is no doubt that as we saw in the earlier slide, OS benefit has been seen, although not the primary endpoint, but it was seen only with ribociclib. So now we will never have that head-to-head comparison, but in the absence of that, with the OS benefit with ribociclib and the highest level of score being accorded by NCCN and ESMO, my first choice for such patients who understand the caveats of the data, but they understand that, then I offer them ribociclib as the first choice. Those who don't understand this, and those who are not really bothered with this, or those who have financial issues with, because we know that we don't have any generic formulation of ribociclib, then I go for palbociclib without any guilt that I'm giving an inferior treatment as such. But then that is my second choice in that setting. Coming to the choice of the endocrine partner, that is the aromatase inhibitor, which is usually very simple. It's either letrozole or anastrozole. and I don't use fulvestrant in endocrine naive patients because of its inconvenience, and there is no data to show that it is superior to letrozole in the endocrine naive patient population.
Yeah, I think you have summarized it, what we do in the clinic very well. And I think there are more to how the patient perceives our treatment, and also to the extent what exactly is the compliance with tablets and what exactly is the compliance with the follow-up visits that actually sets the tone for what we are doing in the clinic. Dr. Sanath, how frequently do you see a metastatic premenopausal woman with hormone receptor breast cancer, and what would be your choice, and how do you see this MCBS score of 5 score for Mona Lisa 7 trial of ribociclib plus endocrine therapy in the premenopausal women?
Sir,
There is a significant overall survival benefit there also.
Sir, we rarely see premenopausal women with metastatic breast cancer, sir, ERPR positive, HER2 negative, because most of the premenopausal they will have aggressive types, that is HER2 positive or triple negative. But when I see, then my choice will be obviously ribociclib only, because the data is strong and data is there only with ribociclib for premenopausal women. But if they are not affordable, then I would like to give palbo because of the financial constraints. But if we go with the data, then ribociclib is the only CDK4 inhibitor approved for premenopausal women.
Yeah, I think you made the right point that most of these premenopausal women do tend to have a clinically aggressive disease despite their hormone receptor being positive. Among these hormone receptor positive patients, these younger women tend to have many problems with the metastatic disease like pleural effusion or liver metastasis. So they require some sort of treatment that is more effective with equal oral response rates, at the same time not damaging the quality of life. And for ribociclib, at least this is being reiterated in the IBC 67 guidelines, especially in the premenopausal women, the right choice trial has clinically shown, I mean, the evidence that is out there is shown that even in a clinically aggressive disease, it yielded a nearly 1 year of PFS benefit compared to that of the combination chemotherapy. And at the same time, these responses are again coming with better toxicity profile compared to that chemotherapy, making it a de facto standard for most premenopausal women, even with a clinically aggressive disease. Across the other lines, it appears that CDK inhibitors can be equally good enough. Each one of them had a consensus of nearly 97 to 95%. So nothing really to differentiate between individual drugs, but especially in the premenopausal women who appear to be having a clinically aggressive disease, probably we have enough clinical evidence to suggest that the combination of ribociclib plus anastrozole can be as good as chemotherapy and even better than chemotherapy with respect to quality of life. Okay, Dr. Vindhya. So this is the guideline that is based upon what is your choice of treating clinically aggressive disease? Would you always go back to chemotherapy, or looking at the right choice clinical trials, would you stick to endocrine therapy options alone?
Sir, ma'am has left. She left actually. She has emergency. She has left.
Oh, is it? Okay. So let's move forward and let's look at some of the quality of life and safety profiles. And this is the summary of quality of life from the pivotal clinical trials. And there are several domains of quality of life that are analyzed across the clinical trials. And if you look at improvement in the health related quality of life, that is significant delay in deterioration of the global health score. It is the Mona Lisa trials and the Palomar trial, Palomar 3 and Mona Lisa 7. And if you look at the maintenance of work productivity, this domain was again significantly better for the Mona Lisa 7 trials. Coming to the increasing diarrhea score, and again, we know that the abemaciclib has significant diarrhea and GI toxicities. So those scores are deteriorated in the Monarch trials. And if you look at the pain scores, clinical relevant improvement in the pain scores, again, that was better with respect to Paloma and Mona Lisa 3 trials. Again, maintain health related quality of life. Again, across these different clinical trials, we have seen consistent improvement with the CDK inhibitors, suggesting that a improvement in the disease status can also improve the overall quality of life. Again, this is the most common adverse effects we see across the different CDK inhibitors. We have higher neutropenia with respect to palbociclib and ribociclib. We have higher diarrhea, grade 3 and above diarrhea for abemaciclib. This again looks like the off-target effects of the CDK inhibitors that we have previously alluded to. That is responsible for all these gastrointestinal adverse effects. And this is a MAIC quality of life analysis, basically the matched, adjusted, indirect comparisons of quality of life and this should be interpreted with caution. But in the absence of head-to-head trials, we have to rely some sort of data building with respect to the utility of individual drugs based upon such analysis. And we can see that the patients were matched based upon their characteristics. Most of the inclusion exclusion criteria was similar across the Mona Lisa 2 and Monarch 3, and patients who in each arm of Mona Lisa, both ribociclib and also the placebo arm, were weighted and matched so that their baseline characteristics are well matched to the corresponding groups of abemaciclib and palbociclib in the Monarch 3. And we can see the time to significant deterioration of symptom scales again was significantly better for appetite loss, for diarrhea, for fatigue and arm symptoms with respect to the ribociclib. Again, the time to significant deterioration did not significantly differ or did not favor abemaciclib across the different domains, and there appears to be some breast symptoms, some financial difficulties, some constipation numerically favoring, but the confidence intervals are quite wide with respect to the abemaciclib. Again, this is a summary of time to chemotherapy. We want to delay the chemotherapy as much as possible. Chemotherapy comes with negative impact on quality of life. And with respect to CDK inhibitors, across these different CDK inhibitors, there is a significant improvement in the time to chemotherapy. And we can see, compared to Paloma, both abemaciclib and Mona Lisa, at least numerically, there is higher numbers here. We can see about 38 months and 17 months for Paloma 2 and Paloma 3, but it is more than 50 months for across the Mona Lisa and Monarch trials. So neutropenia, Dr. Sanath has already alluded that neutropenia is significantly higher with palbociclib and ribociclib, but this is only neutropenia. This is something like a paper toxicities. Fortunately, the febrile neutropenia and grade 3 infections are much lower with the palbociclib as well as with ribociclib. This is because of the different biological mechanism of action of neutropenia caused by CDK inhibitors, which results in a much more faster recovery after treatment discontinuations. And we also have evidence from Right Choice study suggesting that those patients who are taking ribociclib with endocrine therapy compared to that chemotherapy may have higher grades of neutropenia. However, the febrile neutropenia rates is about 3%. Again, grade 3 and grade 4 infections were also lesser with respect to the endocrine therapy combinations. So, Dr. Shikhar, what is your take on symptomatic adverse effects? How do you choose which is better for each patient, and what is easier for you to practice and manage in your clinical practice?
So I think like everyone, all the panelists have said, abemaciclib is something which I think now most of us are moving away from because of especially the data that the long-term data that ribociclib has come out with. I think most of us are comfortable either with ribociclib, and those who cannot afford it to go for palbociclib. So that the GI toxicity issue is now sorted because we are not using abemaciclib so much. Neutropenia, like I said, sir, choosing the right dose is very important. So definitely, as of now, in the metastatic setting, those who are fit patients and not elderly or frail patients, we do initiate with the full dose. But there is a low threshold to reduce the dose once the patients develop recurrent grade 3 or grade 4 neutropenias at the initiation of the next cycle. If they have grade 3 neutropenia, then I think it makes sense to immediately reduce the dose and minimize the treatment interruptions. And fatigue is something which really, it requires a different whole, different multidisciplinary kind of approach to it, involving, dietitians and involving the physiotherapists, etc.
Yeah, I think quick comment from Sanat as well. How do you choose which symptoms are better for a patient? Are you going to say that I am going to use only those drugs which are safe and not tinker with a lot of practice every day? How is your general practice? Would you prefer neutropenia over diarrhea, or you say I'm going to do it on an individual patient basis? Dr. Sanat? I think he's not available. I think we always gravitate towards grade 3 and grade 4 toxicities, which that we can easily manage. And with respect to my own practice, I would say that diarrhea is significantly worse with abemaciclib. Probably I will try to use some antimotility drugs prophylactically. Fatigue is something that we cannot predict in any patient. We have to be vigilant about anemia. We have to be vigilant about electrolyte disturbances. We have to be aware of other depression and other medications that the patient is taking. We need to be very closely monitoring the drug interactions and such. So let's look at the elderly patients. I think for the want of time, I'll try to rush through this. This is basically a 76-year-old lady with metastatic breast cancer having multiple comorbidities. So Dr. Shikhar, your quick comment about treatment goals for these elderly patients and what are the treatment choices that you go through?
Treatment goal is, sir, to palliate her symptoms and to prolong her life and give her a good quality of life. And she is elderly lady with HR positive with only bony metastasis. So treatment will be CDK4 plus AI. AI would be letrozole or anastrozole. CDK4 would be ribociclib first choice. Starting dose elderly, probably 400 mg is the way to go, along with the addition of either bisphosphonate or denosumab, depending on her renal function and her finances.
Yeah, well put. I think this at least gives us confidence from the Mona Lisa pooled analysis that the quantum of benefit with respect to the overall survival across the age groups is not very different. We also have real world evidences from Ribana study or also from the complement 1 study that suggested that regardless of age, the combination of ribociclib with the endocrine therapy has maintained PFS and time to treatment progression and comes with a safety profile and improved quality of life. Again, this is the real world effectiveness from Germany and is an ongoing trial that suggests that the proportion of patients developing neutropenia and fibrillar neutropenia are similar across both patients who are more than 75 years of age and less than 75 years of age. And coming to the Monarch trial, we don't have robust data in there. At least from the forest plots, it appears that both the groups appear to be benefiting similarly, especially in the Monarch 3. However, in the Monarch 2, there appears to be much more worse benefit for the patients who are elderly. The quantum of benefit with respect to the absolute numbers of overall survival were not available for these Monarch 3 trials. However, the exploratory analysis from Monarch 2 and Monarch 3 suggests that these patients do experience higher grades of adverse effects, including diarrhea. This is from the palbociclib, except for the Palomar 3, which is a second-line trial of utility of fulvestrant plus palbociclib. Rest of the other groups of Palomar 1, 2, and Pearl, it appears that there is a little less benefit for the elderly patients. This is the complement, which is a complement to the ribociclib and Mona Lisa trials, and we can see that there is increasing toxicities with increasing age. We can see that treatment discontinuation, which is about 9 to 6%. About 10% has improved to 20%, and again dose reduction, which is about 69%, increases to 73%, and additional treatments for additional adverse effects is about 73% for younger age. It is about 80% for the elderly age. So even with ribociclib, we need to be vigilant that these patients are going to have increasing toxicities. The age is going to be a factor, and we need to be monitoring them with respect to geriatric assessment. And if they are appearing to be fit, we should not deprive them of the CDK inhibitors. So I think Dr. Shikhar has made it very clear that we are going to use a combination of CDK4/6 inhibitors, especially for those patients who are ECOG performance 1 with well-controlled comorbidities and geriatric assessments suggesting that they have a physiological sustainability. So I think for the want of time, I'm just going to rush through most of the slides. This is the utility of ribociclib with respect to visceral metastasis. We can see the PFS numbers and overall survival numbers more or less similar, whether the patient has visceral metastasis or liver metastasis or both. We can see the hazard ratio 0.79, which is again consistent across the groups. Again, there are no safety signals for those patients who are having visceral metastasis. This is the right choice study design. Does this give confidence to use combination endocrine therapy in visceral metastasis, Dr. Shikhar?
Absolutely, sir. No doubt about it. Even if my surgeon refers to me saying, "Arey, patient has visceral metastasis, aggressive disease, why are you not giving chemotherapy?" This is the trial that I quote to the surgeon that, see, this is outperforming chemotherapy by twice as much. With better response rate, more durable PFS, and better fewer adverse events.
Yeah, what is to be commented about this study design that nearly 2/3 of the patient have significant result metastasis, and they still did significantly better than the chemotherapy with less adverse effects of infections. So that definitely gives us more confidence. And there is again, discontinuation rates are much more higher with chemotherapy, and most common reason for discontinuation is disease progression. This again, there is no doubt that the quality of life is going to be better with the endocrine therapy. This is again Monarch 3. Do you want to look very closely into the numbers, because numbers are not supposed to find a difference? What is your comment here, Dr. Shikhar?
This is the subgroup analysis of Monarch 3 in patients with
Yes.
visceral metastasis.
There appears to be
I
no
think
benefit.
this is unplanned subgroup analysis, and I have not looked much into it.
Yeah, I think that is it, and we need to look at the crossover that happens here. So there may be some improvements or deterioration based upon the toxicities, but over a period of time, the abemaciclib again has its own effect on the disease, and the outcomes may be over a period of time better. But these are the numbers that are not supposed to be controlled. We cannot read much into it. Again, this palbociclib again doesn't appear to be having a lot of benefit with respect to the visceral metastasis. Again, this is an unplanned subgroup analysis. Again, we cannot look a very scientific discussion about it, but we have at least my right choice trial for ribociclib for making that choice in those patients who are having visceral metastasis. So I think the evidence that out there is again clearly in favor of CDK inhibitors in combination with either anastrozole or letrozole or fulvestrant, even in those patients who are having visceral metastasis. So this is again, so let me just conclude with this summary slide. Again, CDK4/6 inhibitors in combination with the AI or fulvestrant is the de facto standard of care in frontline management of hormone receptor positive, HER2 negative advanced breast cancer. There are obvious differences in on and off target binding with respect to individual drugs. Most of the off-target effects can result in side effects. Again, over and above, the utility of CDK inhibitors has maintained survival and quality of life in patients, especially in the advanced breast cancers. However, there is at least evidence to suggest that in monoresearch trials, ribociclib is the only trial to show statistical significant and clinical improvement, meaningful frontline OS benefit across all the pre-specified analysis, including the menopausal status and including the additional endocrine therapy partner. And this benefit is even in those with poor prognosis, including high disease burden and visceral metastasis. So with that, I would like to conclude and hand it over to the organizers. Thank you very much.
Yeah, so thank you, Dr. Rakesh, Dr. Vindhya, Dr. Shikhar, and Dr. Sanath for a wonderful panel discussion. I think final verdict definitely goes more in favor of Ribo over Palbo and Abema for obvious reasons. I think Novartis should be really happy. Yeah, thank you. So with that, we'll move ahead for the next session.
Now we move on to the lung cancer session. I would like to invite our next speaker, Dr. Deepak Kopaka, Senior Consultant, Medical Oncologist, Care Hospitals, Hyderabad. Welcome, sir.
That will be covered in the panel discussion. So I'll just keep it simple in terms of updates. There have been some trials, which I'm not a very big proponent for the neoadjuvant ADAURA, but worthwhile considering such regimens in patients with poor lung functions. Rehabilitation treatments are being planned to buy some time. So the neoadora trial, the key takeaway from the study, if anything, is neoadjuvant osimertinib with or without chemotherapy should be considered as treatment for patients with resectable EGFR metastatic NSCLC for whom neoadjuvant therapy is recommended. So is neoadjuvant therapy recommended for all lung cancers? At least in the driver mutant positive patients, it's currently not recommended. It's recommended in patients with early stage lung cancers where immunotherapy is a treatment of choice. Perioperative immunotherapy probably is the recommended choice in such situations. But again, in EGFR positives, I'll be discussing about two such studies. One is use of osimertinib, the other is the use of alectinib in mutation positive lung cancers. So neoadora has included patients from stage 2 to stage 3B NSCLCs, only classical EGFR exon 19 deletion and 8R mutations were included. 1:1:1 randomization where patients receive neoadjuvant chemotherapy for 3 cycles, which was the comparator arm, versus osimertinib single agent and osimertinib plus chemo followed by surgery, and nearly more than 90% of the patients received adjuvant osimertinib post-surgery across all 3 arms. So the primary primary endpoint was major pathological response. So this was a little surprising, but again makes sense where post-surgery all patients were eligible to take adjuvant osimertinib. So the primary endpoint of the study was major pathological response. Secondary endpoints were event-free survival, PCRs, and nodal downstaging. So the MPR rates were statistically significant, higher in both OC plus chemo versus OC alone. Not stark difference between OC monotherapy versus OC plus chemo versus chemotherapy alone. The MPR rates were only 2%. So almost a 24 to 25% difference in terms of response rates. A consistent benefit across all the arms with the use of osimertinib, as expected, was present in the study. So the PCR rates were a little surprising. The PCR rates were again not great. Actually, the PCR rates were highest with OC monotherapy compared to OC plus chemotherapy. That was 4% versus 9%, and no PCR rate. Only 2% patients achieved PCR in the chemotherapy arm. Nodal downstaging, staging EBUS was not recommended consistently across patients, but wherever there was EBUS staging done, use of osimertinib or osimertinib plus chemo led to a downsizing of the N2 nodal disease burden. So in conclusion, neoadjuvant OC with or without chemotherapy demonstrated a significant improvement in terms of major pathological response rates. The PCRs again were not really great. Interim EFS was again in favor of osimertinib arms. But again, the point here is, as if you can see the curves that were later shown in the JCO publication, there was significant overlap of the curves once the patient received adjuvant osimertinib. So downsizing of the nodal burden was seen, and at least in patients where we planning for pulmonary rehabilitation in patients with COPD, or patient need time for proceeding with surgery for various other reasons, I think single agent osimertinib still is an option to be considered. Now, what do we do in patient? What is the role of chemotherapy? Again, based on the EDORA data, though it was post hoc analysis that the benefit of chemo was once with the use of osimertinib, the benefit of chemotherapy was not significantly there. Again, in this study, that benefit of chemotherapy, at least in terms of MPRs or PCRs, was not significantly different. Now, these are actually practice-changing studies. The tarlatamab is a small cell cancer, at least this subpopulation of lung cancer, I think there were really practice-changing studies that came up in the ASCO meeting. One in regards to the Delphi 304, and the next is being IMPORT. The problem with IMPORT is lack of lurbinectedin in India, but again, in patients with in patients with post-chemo immuno and maintenance immunotherapy, addition of lurbinectedin significantly increased PFS and also met the statistically significant OS advantage. Similarly, the tarlatamab regimen, that is the Delphi 304, here in patients with SCLC, patients were randomized post-chemo immuno or chemo alone, were randomized to tarlatamab or chemotherapy of investigator choice, that is topotecan, lurbinectedin, and amrubicin. So here, the interesting point is they had patients with chemotherapy-free interval of less than 90 days, 90 to 180 days, and more than 180 days. So there was no arm that received the prior carboetoposide or cis-etoposide regimen in the study, but again, so the standard of care of chemotherapy arms included topotecan, lurbinectedin, and amrubicin. The primary endpoint was overall survival. Secondary endpoints was progression-free survival and patient-related outcomes. Both arms were well balanced, and again, DLL3 expression was seen in 95% of the patients. So again, there was no differential benefit in patients having no DLL3 expression versus patients having DLL3 expression. So all patients with small cell carcinoma lung would eventually benefit with this BiTE, which targets DLL3 and T-cell engager. So there are multiple other trials coming up in the ESMO meeting, multiple other drugs which would be discussing about a similar DLL3 targeted strategies in small cell lung cancer. So as we can see here, almost a 40% risk reduction in terms of death was seen with the use of tarlatamab. This was very convincing in terms of 1-year survival. So this is a subpopulation of patients who have progressed on chemotherapy, immunotherapy, and for the first time, the median survival in the second line setting reached more than 1 year. Now, interesting fact is the Caspian study and the IMPOWER study that were initially evaluating the use of immunotherapy in the frontline setting were the first to show an overall survival in the study arm, in the experimental arm, to reach more than a year. Now, here is a very interesting fact. So it was the benchmark that, okay, finally we have drugs that are allowing patients to survive for a year's time. Now we have a drug that is being used in the second line that has really shown an overall survival of 13.6 months. So this was very interesting. Now, point for consideration here is, again, there's consistent benefit across all subpopulation, like population of patients who have chemorefractory disease, that is disease progressing within less than 90 days, has shown significant benefit with the use of tarlatamab. And patients with liver metastasis, brain metastasis, again, showed significant benefit with the use of the drug like tarlatamab. Now, just like any other, so tarlatamab is similar to immunotherapy, where you might not see a significant PFS advantage. Again, tarlatamab versus chemotherapy, you can see a significant proportion of patients progress till 3 months. And at post 3 months in patients who respond, we see that after at least 6 months, you can see a flattening of curve, though a lot of censoring is there. But again, a significant proportion of patients, if they reach the 6-month interval without progression, they probably might benefit significantly with this drug. But again, the point is, though we see that curves overlapping till 3-month interval, there is a significant advantage in terms of overall survival. The median survival PFS difference is less than a month. And again, though it favors tarlatamab, it is again not clinically. I wouldn't give this drug to see an improvement in PFS. Probably OS is what drives use of such drugs in practice. Overall response rates were again significantly better with the use of tarlatamab compared to chemotherapy. The major side effects in terms of tarlatamab, where the initial publication which used tarlatamab again showed that there were significant ICANS and cytokine release syndrome, were the side effects of this drug, which predominantly is a problem that we encounter in hematological malignancies. Even in this study, if you can see, though cytokine release syndrome were more in tarlatamab, most of these cytokine release syndromes were grade 1. There was a differential dosing. First cycle patient received a different dose, and second and subsequent cycle, there was a dose escalation, and use of steroids significantly reduced these side effects. So tarlatamab, I think, is practice changing. If the drug is available in India, I think we would consider using this regimen in the second line. There was almost a 40% reduction in the risk of death compared to chemotherapy. Benefit extended to those patients with poor prognostic factors such as platinum-resistant and brain metastasis patients. There was an improvement in terms of symptoms, that is dyspnea and cough, compared to chemotherapy. Now, again, this is one practice-changing study. There was always a debate of whether the perioperative regimens fare better than the neoadjuvant regimens. Now, at least on practical front where finances come into play, I think Checkmate 816 lays a clear answer that there was significant improvement in terms of 5-year overall survival. This is actually after multiple analysis trying to assess the benefit in terms of overall survival. Again, here we all are aware of this study where nivolumab 360 milligram, 3 doses were given along with chemotherapy, which was based on the histopathology report. Here, the primary endpoints were PCR and EFS, and both of them were statistically significant and published earlier. The key secondary endpoint, which is overall survival, again, this was presented in the final analysis at ASCO. There was almost a 10% incremental difference in terms of absolute benefit with the use of 3 cycles of neoadjuvant chemo and nivo, and a 30% risk reduction of death was seen. Again, when we see again, these are again cross-trial comparisons. We compare this to the keynote 671 study. Again, at 5 years, we see more or less similar survivals in that study. Significant benefit was seen in patients having PDL1 more than 1% compared to patients with PDL1 less than 1%. The benefit is seen in both stage 1B, 2, and 3A. The benefit, now again, the problem here is the 2Bs and the 1B, the 2 and the 1B population. Even the control arm fared better than the patients having 3A disease. So that was the reason the benefit was more, as we can see here, in the 3A population than the 1B or 2 study. So again, the magnitude of benefit, as we can see here, is different between 3A and 1B and 2 population. But this was again in favor of nivo plus chemo population. I think with more mature data, we can see that benefit continues to exist even in 1B and stage 2 patients. So the patients with PDL1 less than 1%, the benefit probably is not as great as compared to patients with PDL1 more than 1%. But again, at least the NCCN guidelines do not recommend recommend this drug irrespective of PDL1. The keynote 671 again shows benefit irrespective of PDL1 levels. But as we know, higher the PDL1, better would be the responses with immunotherapy. Again, the lung cancer specific survival, there is almost a delta of 10% between the addition of nivo to chemo versus chemo alone. The 5-year event-free survival was 34 versus 49%. Exploratory analysis, I think that one subpopulation of patients where I would consider the Checkmate 770 population. Again, Checkmate 770 had 4 cycles of chemo immuno followed by immuno. There was a match propensity scored analysis that was discussed in last year World Cancer for Lung Congress, where patients where adjuvant immunotherapy showed more benefit. Again, this was cross-trial comparisons. was in patients who did not achieve pathological complete response and patients who had PD-L1 less than 1%, continuing the adjuvant immuno probably makes more sense. We don't have a study to directly answer this question, but at least in patients who fail to achieve a PCR, probably continuing the immuno in the adjuvant space makes more sense. ctDNA again, so an interesting take as per this study, and again across studies here is patients who have no ctDNA clearance prior to going to surgery. These patients end up not having pathological complete response. In patients having a ctDNA clearance, at least there is a fair chance, there's almost an 80% chance that these patients have pathological complete response. So again, in patients having persistent ctDNA, they eventually wouldn't have PCR, and these patients, there is a benefit of continuing adjuvant nivolumab. So that is in terms of Checkmate 816. I think we have a study with the neoadjuvant setting. There's the only phase 3 neoadjuvant study which showed an overall survival advantage. And there's the only actually phase 3 published neoadjuvant study in this population. So I think this is a go-to regimen in most of our patients. In patients achieving PCR, I think that's the end of treatment. In patients not achieving PCR, we really have no answer, and continuing immunotherapy as per the Checkmate 770 makes more sense. The Alneo study again is similar to the Neodara study. Here, only 33 patients were recruited. Only 2 cycles of alectinib, that is over 2 months, alectinib was given. There, 2 months, 1 week, the 9-week treatment was given with osimertinib, and then patients were posted for surgery. And the primary endpoint was major pathological response, expecting that at least 40% of the patients achieve major pathological response. Here, 42% of the patients achieved major pathological response, meeting the primary endpoint of the study. And the CR rates were around 12%, higher than what we saw, but again, the sample size is much smaller here. The interesting part here is patients not undergoing surgery. Around 5 patients did not undergo surgery. Now, that is a real world problem. Patients responding to TKIs, again, or to complications to these drugs, you end up missing these patients from getting a definitive treatment, which is surgery. So at least in the mutation positive patients who are fit and who are operable upfront, I think it's always better to consider upfront surgery. That's again my take, dwelling into the details of this data. So again, patients who underwent surgery, around 86% of the patients underwent surgery and 15% did not undergo surgery. Now you go back even to the perioperative or the neoadjuvant studies, around 15 to 25% of the patients failed to undergo surgery with the use of neoadjuvant therapies. Again, that's a consistent pattern that we see across trials. But again, in the previous study, that is the Neodara, I think less than 10% of the patients did not undergo surgery. This probably is in continuation to the ELINA study. So certain patients where rehabilitation or you need to buy time before surgery, I think we can consider the neoadjuvant alectinib, or patients post-operative can be kept on the ELINA study, as per the ELINA study. So I think Neodara, according to me, is not practice changing, but can be considered in patients where neoadjuvant therapy needs to be given. Similarly, with the Alneo study, Checkmate 816 and Delphi 304 are definitely practice changing studies from this aspect. Thank you.
Thank you, Dr. Deepak, for that wonderful presentation. We do have some practical questions in the chat by Dr. Santosh. I think we will take 2-3 questions. So I think one first question is Neodara in practical scenario for all N2s, Dr. Deepak.
So again, sir, the point here is something that I would like the broader audience to understand is none of the perioperative or the neoadjuvant studies are given to make a borderline resectable disease to become resectable. These diseases are across studies have taken patients that are operable upfront. So N2, the problem with N2 is what happens with N2. What eventually is the problem with N2 is like N3, N2 is also a disease that would say that these patients have more systemic recurrences. So I'm not against giving the neoadjuvant, but again, you can benefit by giving the adjuvant. The same magnitude of benefit can be given by giving the adjuvant regimen. There is a sheer 10 to 15% of patients who end up not undergoing surgery. Now, that is a definitive modality. Any targeted therapy, for that matter of fact, is even today's date, we don't see these patients becoming cured. We know, like from the data coming from GIST, there is a significant proportion of patients who relapse once the drug stops, or even on drug, there is a chance of resistance. So definitive modality of treatment still continues to be surgery. So again, immunotherapy is a totally different ballgame. But immunotherapy is you're priming the body's immune system, and they're giving a neoadjuvant primes the immune system and has shown overall survival advantage. So that is my take. Again, this has been my consistent take in terms of this. There was one more question, sorry, it's in the chat box.
PDL1 less than 1.
Less than 1% is not a population of patients. These are all post-hoc analysis. I'm stratified though. Now the point is, would I not do checkmate 816? As per the EMA, probably no. As per the NCCN, probably yes. What would I do practically in such situation? I would rather go with 4 cycles based on the keynote 671. Now, keynote 671, at least, probably again, PDL1 less than 1%, it showed a trend towards improvement in survival, not powered though. So keynote 671 is my go-to regimen, because even their patients, there is a significant chance these patients wouldn't get pathological complete response. I would stick to the regimen and continue the pembrolizumab in the adjuvant space. So that is my take. Yeah.
Yeah. So from my end, I just want to ask one more question. So in practice, when you give, when you do checkmate 816, do you really have any practical challenges for surgeon on a real-time basis? Yeah, what is their,
So at our center, what our surgeons feel is patients having hilar lymph nodes or the station 4R lymph nodes that are not invasive but a little bulky. Post the neoadjuvant chemoimmunosetup, there's a lot of fibrosis, sir. So when they have to ligate the bronchus or the arteries at the hilum, so that's becoming a challenge. Other than that, now if you have to go back to the data per se, the operability is not different. If you go back to the checkmate 816, in fact, the operability rates were better. The surgical duration was better with the neoadjuvant therapy. Practically, in our setup, our surgeon complained that hilar lymph nodes create a difficulty in operating and ligating the vessels.
Yeah. And financially, little, affordable, non-affordable patients, your go-to regimen will be definitely checkmate 816.
Yeah, sir. Checkmate 816 at a dose-reduced fashion, sir. So I go back to the 3 mg per kg, and it comes down significantly if we do that. In most of our patients are around 50-60 kgs. So I think that would help. You just buy one vial, you can get away for the next 2 vials in practice. Again, there are other ways of doing it, but I do that. I've done that in a couple of patients, sir.
Yeah. And the last question, I think, any role of ctDNA monitoring in early stage NSCLC, prognostic monitoring, treatment guidance?
Sir, prognostic monitoring, I think, again, ctDNA is prognostic in ways that a patient has no ctDNA clearance. These patients have no, their outcomes are worse than patients who have ctDNA clearance, sir. Now, checkmate 816 was very clear in this. That was their initial analysis also, where the ctDNA patients who did not have clearance, patients who were ctDNA positive at baseline, who did not have clearance, none of these patients achieved pathological complete response. I think easier for us, cheaper for us is the pathologist telling whether the patient has got pathological complete response or not. So I think I would not really use ctDNA as a metric as MRD for follow-up, because again, the center has to have the baseline, and also subsequently ctDNA has to be done at greater sequencing depths, which becomes costly. How frequently we do it? When do we intervene if the ctDNA comes positive? These are all challenges, sir. In terms of prognostication, which is what ctDNA really helps, I think the better surrogate is always pathological complete response yeah, that's my understanding with terms of
yeah, so I was just going through the literature, as I think you are well aware of that. So ctDNA positivity detects the recurrence almost 6 months earlier than the imaging.
Yeah.
I don't know whether it is exactly the data or not. Yeah. So I think with that, we'll just go for the next session. Thank you, Dr. Deepak. Yeah.
Thank you, Dr. Deepak. Now, I would like to invite our next speaker, Dr. Monica, Consultant Medical Oncologist, KIMS Hospital, Hyderabad. Welcome, ma'am.
Thank you. Thank you, Venugopal sir, for giving me this opportunity. I'll share my slides.
So our next speaker is Dr. C. Santosh Kumar. Sir is a Senior Consultant Medical Oncologist, Star Hospitals, Hyderabad. Welcome, sir. Please take this forward.
Thank you, Dr. Venugopal sir, for giving me this opportunity. And thank you, AstraZeneca, for providing me this chance. So basically, let's discuss this important thing. In an unresectable stage 3 NSCLC, what do we have data? How we have moved from the Pacific to the LAURA. So we all know that stage 3 is not a single entity. It's a basket of multiple tumors where we can manage in a multiple different way. It includes as early as potentially resectable T4NAs, T3N1s, which are potentially resectable, to an unresectable where there is N3 or N2 bulky or multi-station bulky. So it's a conglomerate of all where there are multiple treatment options to each of the patient. So ultimately what decides everything is, in the case of this stage 3 is, it's a multidisciplinary tumor board where all the stakeholders should sit together and they have to decide regarding the treatment strategy. There was an audit that showed that less than 20% and less than 5% of stage 3B receive surgery as a part of this treatment, where we have to have a unison in deciding what is the correct kind of treatment. So as we have seen, this is an 8th edition of AJCC. The division is very, very important. N3, straightforward, unresectable, we know. N2, that is invasive, is unresectable. N2 bulky, in T1 and T2, we don't know. But predominantly in other, where N2 is bulky, is unresectable. So overall, N3, N2 invasive, and N2 bulky. These are the subsets that are unresectable, where N2 multi-station, non-bulky, non-invasive. These are the things which are potentially resectable, where alternative treatment also can be offered. When we see based on the pathological stage, when 3A is going to 3C, the overall survival is half from 3A to 3B, 40 months to 20 months, and again 20 months to 10 months. So there is a clear-cut demarcation. As similar is the 2-year OS as we see in this scenario. So as I told you, the important part is multidisciplinary assessment. We have to take in consideration the patient-related factors, the performance status, the comorbidities, the pulmonary functions, whether the patient might tolerate pneumonectomy or lobectomy, the cardiac reserve, patient preference, and most importantly, the social financial status. On the tumor-related factors, as we have discussed, whether there is N3 station, N2 station, if in case N2, is it invasive, is it multi-station or single station, and the feasibility of technical resectability, and can the patient tolerate radiation, because sometimes there is a no-fly zone where sometimes it becomes difficult. So to define it, so the important factors that come is whether is there any mutation positive, that is EGFR and PDL1. Based on that, we take our guidelines or advice based to the patient. So this is the guidelines that you can see, where in majority of the stage 3, definitive concurrent chemoradiation is the standard approach, where whenever these are out of surgical candidates, where we give radiation along with chemotherapy. So the completion rate of CTRT varies because we entitle a lot of complications in CTRT. So if we see the international data, approximately 60% complete the schedule in case of concurrent, as we have seen. Radiotherapy only complete in 30% and chemotherapy in this one. So this is the data that we have to understand. And also, what should we do after completion of CTRT, where we have many scenarios where some residual mass is less. Various strategies were used, whether we should use docetaxel, where we should use consolidated with dosi and cisplatin, pemetrexed, or should we increase the radiation, or should we give target in the form of geftinib or cetuximab. None of the strategy fails to show that consolidation, chemotherapy, or various augmentation of radiation or targeted therapy protocol fails to show any significant response. This is an important landmark study, specific study. I want you to take consideration on 2-3 important parameters that I would tell. Here you can see in the inclusion criteria, mutation testing was not considered in decision making. That is the first point I want you to understand. There was no mutation testing. And what is the duration after radiation completion to start of this immunotherapy? As early as day 1 to 42 days. This is the second point. They randomized to durvalumab and placebo. Durvalumab was given for 12 months. One important point, irrespective of the mutation status they have taken, and even 1 day after radiation also they have taken, because we have a lot of concern that if we start the chemo, the durvalumab early, is there any risk of pneumonitis is the point we always have in our mind. Let's dissect out how much is the risk of this pneumonitis in this scenario. As we all know, Pacific trial at 5 years landmark at 60 months, the overall survival of almost 10 absolute differential point, which is clinically and statistically important, and it is meaningful. So it's a game changer in the field of lung cancer, where 10% of improvement of absolute point of overall survival at 5 years, it's an important hard landmark which we can take. And the overall survival at 5 years was 40%. 40% of the stage 3B, 3C survived, where it was only around 20% in the basis data. So what are the subgroups that derive benefit? Almost all subgroups have derived benefit. I want you people to draw your attention to this one. That is EGFR mutation positive. It crossed the missed line. That is one thing. And PDL1 less than 25, it crossed the missed line. So this is what, but they did post hoc analysis, even in 1 to 24, it showed benefit. This subgroup analysis are difficult to understand, but this EGFR part, it clearly has missed the benchmark figure. So we should be skeptical in that particular subset. So PFS, as you see, yes, they showed very good division and good difference in almost 33% benefit at 5 years. So at 5 years, 33% is the PFS difference and 10% is the absolute overall survival benefit. So similar coming to the, in terms of the PFS, almost all groups except the mentioned group of EGFR positive, all groups irrespective of PDL1 had showed improvement in this criteria. So the most problematic or the most worried side effect in patients receiving this one is pneumonitis, because they have received extensive lung radiation and what is the amount of pneumonitis. So not major, you can see 33%, and even in the placebo arm, there is residual amount of pneumonitis. So this is another important data point according to me. Those patients who have started durvalumab within 2 weeks after completion, that is less than 14 days, versus or later than 14 days after completion of concurrent chemo-RT, the timing of starting of consolidation durvalumab post chemo radiation doesn't impact the outcomes. This is one of the important things where we can start right away after this thing. And the PFS and OF in specific EGFR mutation, you can see both in the experimental arm and the control arm, it was more or less overlapping. That is, this is the subset that did not really get benefit. This was understood later subsequently, where the patients with targeted mutations do not see good benefit. These particular subset requires something special treatment for improvement of this one. So EGFR mutation subgroup did not receive any PFS or OS benefit. So to improve the outcomes is this particular subset who did not derive benefit from the immunotherapy protocol. They have formulated a new protocol, and that is the LAURA trial, where I want again you to see 1 or 2 points. They have included more than 18 years, both the common mutations in the form of exon 19 deletion and L858R, where this one, and maximum interval between the last dose and CRT in randomization is 6 weeks. And the important thing is osimertinib duration. When you see the duration, there is no 1 year, 2 year, 3 year. It is continuous. So this is another point I want you people to understand. So the duration of osimertinib is as long as feasible. It's not like limited to 1 year, 2 year, 3 year, where we see in a lot of adjuvant trials, there was time limited. Why did they choose? Let's discuss the reason for choosing. So the baseline characters are properly matched in terms of the type of EGFR mutation, the histology, and because of randomization, all were well matched. So this is a remarkable difference in the benefit in terms of PFS. You can see the hazard ratio of 0.16. This kind of hazard ratios are like fantastic or the blockbuster kind of drugs where there is an immense need. You can see here those patients who have completed CTRT with EGFR, if you do not give an EGFR as early as the initial 3 months assessment, they fall and progress. So this is a dire need of osimertinib in this particular subset of patient. Such tremendous amount of hazard ratio we have seen with olaparib trials in ovarian cancer. and some very few trials in the form of where in the metastatic osimertinib also we have seen and adjuvant osimertinib, but such kind of hazard ratios of 0.16 I am taking even without the publication of OS data. So this is such a game changer in this. If you see the progression-free survival as per BICR blinded, it also correlates to 0.19. So this is a fantastic forest graph where you can see all the subgroups have derived benefit irrespective of whether they receive concurrent or sequential, whether anything responds irrespective of response to prior chemotherapy, irrespective of the stage or current smoking. This is the power of the precision or targeted therapy that we discuss in medical oncology. And you can see the waterfall plot where there is significant difference where the upward to downward conversion occurs very early. This means that there is a very early beneficiary, and the thing is overall response rate and disease control response rate are fantastic in this scenario. The other important thing I want you people to draw your attention is it protects the brain from developing metastasis. You can see 29% is the metastasis if we do not use, and 8% is the metastasis if we do not do. So especially it prevents developing of brain and lung metastasis. As you can see, the overall survival that tends to separate. This is because 81% of the patients have crossover to osimertinib. So if 80% have crossover, then you might not have a significant overall survival benefit. The separation of PFS with the hazard ratio itself, I'm confident enough to offer to many of my patients. So there is no major increase in pneumonitis that we worry whether if we give this drug. So longer treatment exposure and the adverse effects, as we all know, are generally management. By now, we are well versed with managing the side effects of osimertinib. As you can see, the radiation pneumonitis rate was not majorly different between two, and we all know the dry skin pruritus and all occurs with patients on osimertinib. So the other thing is this one. This is an important slide. So why was the indefinite schedule of osimertinib chosen? Many trials we know in the adjuvant trial, the thing was 2 years, 3 years. Whatever happened is whenever these they stop taking the drug, there is fall of the OF and PFS, they converge. So it is the long-term persistent of the drug that is important to derive the long-term OS. You can see the fall off as soon as they stop after 3 years, there is fall in the ADURA. So taking insights from this data, they have chosen a strategy of continuous thing in the LAURA trial. So this one is also promising. So as we understand, if it is EGFR mutated, give osimertinib. If EGFR non-mutated, durvalumab. Irrespective of ALK mutation or anything, the data is convincing for durvalumab. So this is what 1 year of durvalumab, it improves the thing, and EGFR mutation is very important. The PFS of almost 40 months versus 5.6 months. So it's a standard of care for patients with unresectable post-CTRT to give indefinite amount of osimertinib. This is the disclaimer and the prescription thing. Thank you very much once again for giving me the opportunity and time for sharing this important data points. I feel this data is landmark and we are already using, and it's important that the mistakes or the learning from the previous trial, we learn and implement in the future trial. That was what followed. As we have seen the PFS drop after 2 to 3 years, they have corrected in this trial. So thank you very much again, Venugopal sir and AstraZeneca for giving me this opportunity. Thank you.
Yeah, thank you, Dr. Santosh. So definitely, I feel that LAURA is practice changing. It has got the practice changing potential. So osimertinib consolidation after chemoradiation, EGFR mutant NSCLC, and then the locally advanced stage, unresectable stage 3, definitely. I mean, undoubtedly, the data speaks for itself, I think, in this thing.
Yes, sir. Yes, sir. Yes, sir.
Yeah. Thank you.
Thank you very much, sir. Thank you very much.
Now I would like to invite Dr. Venugopal for his talk.
Yeah, I'll just try from my end to share the slides. Just let me. Okay.
So shall I share your slides?
Just what? I'll just share from my end once.
Okay, sir.
So is it visible now?
Yes, sir, it's visible.
Yeah, so I'll just go ahead with that then. Yeah, so a very good evening to all. So my topic for today will be sponsored session by Roche. So role of Tecentriq in first line patients with advanced NSCLC not eligible for a platinum containing regimen. So these are my, I think again, slides are not moving. Am I audible, Avni?
Yes, sir, you're audible.
But somehow my slide decks are not moving.
Shall I share it from my end, sir?
Yeah. Yeah, I think better. I'll just stop sharing here. Yeah, please.
Is my screen visible?
1 minute, 1 minute.
Sir, is my screen visible?
No, I'm just let me. Yeah, is it your screen? Yeah, just
Yes, sir, this is my screen.
next slide, please. Next slide.
Just a second.
Yeah, so now it's visible. Yeah, these are my disclaimers. Yeah, next slide, please. So lung cancer disease background being, I mean, if you look at the incidence, mortality and prevalence worldwide in 2022, so 81,748 new cases and deaths being mortality is close to 75,000 and 5-year prevalence is 1,13,990 cases. So it is definitely the fourth most common cancer and one of the leading cause of cancer deaths. So it accounts for around 85% of all lung cancers is by NSCLC and majority are diagnosed at stage 3 and stage 4. Next slide. So definitely there is an unmet need for the treatment of options for patients with lung cancer who are unsuitable for platinum doublet chemo. So many patients who are diagnosed with lung cancer, they are considered unsuitable for platinum doublet chemo because of many reasons or issues. In real world settings, more than 40% of the patients who are diagnosed will have an ECOG performance status of 2 or more than 2 and substantial comorbidities. So these patients are excluded from most of our phase 3 immunotherapy clinical trials. So the patients with ECOG PS2 or more than 2, they have poor survival than those with ECOG PS0 and 1 regardless of the treatment what they receive. So average age of the patients with NSCLC at diagnosis itself is more than 70 years as we know and as we encounter in many of our day-to-day real-time clinical patients. So these patients often have the comorbidities, contraindications, or they are simply deemed too frail to receive any platinum doublet chemotherapy. Next slide. So the many factors are taken into account when platinum eligibility is assessed. So which are well known to all the practicing oncologists. So stage 4 NSCLC without genetic aberrations or with contraindications to IO. So irrespective of histology, we PDL1 expression level. So we have certain issues, renal issues, cardiac issues, CNS issues, pulmonary issues, nutritional issues, and psychiatric issues for these group of elderly patients, and of course comorbidities. So the factors which are considered, rarely the standalone criteria like very old age or very poor PS are considered, but in majority of our cases, combination of factors contribute to the decision for or against the platinum doublet regimens. So where the physician's clinical judgment is the guiding principle across trials and the clinical practice. Next slide. So the current NSCLC guidelines recommend the treatment mainly based on the performance status and age cutoffs, while there is lack of defined criteria for platinum ineligibility within this subgroup of patients. So the guidelines state that the first line treatment for these patients with PS2 or more than 2, platinum based doublet should be considered in eligible patients with PS2, preferably carboplatin. Otherwise, single agent chemotherapy agents, gemcitabine, vinorelbine, docetaxel, or pemetrexed is definitely an alternative option. And insufficient data are available to date on the use of monotherapy immune checkpoint inhibitors for the patients with PS2, but definitely this option can be considered. Patients with PS3 or 4 should be offered best supportive care. And for the elderly patients with advanced NSCLC, treatment recommendations with good PS and adequate organ function, they are similar to the general population, but above 75 years, we don't know the benefit of chemotherapy plus immune checkpoint inhibitor combination. And the toxicity of the platinum doublets should be discussed. However, carboplatin is the preferred option when toxicity is deemed tolerable. For patients not eligible for doublet chemo, definitely single agent chemo remains the standard of care. So the clinical practice, the main reasons to avoid platinum based regimens older age, that is more than 70 years, is seen closely in the range of 75%. Comorbidities again 70%. ECOG PS2 are more than 250%. And social issues or family issues in terms of persons, I mean, no lack of caregivers, all these also contribute. So in most of these cases, close to around 88% of these patients, a combination of these factors was considered to guide the treatment decision and thereby label them as platinum ineligible. Next slide. So again, unfit for cisplatin based chemo, unfit for carboplatin based chemo, unfit for single agent chemotherapy. We have criteria to define these patients. For example, if you are talking in terms of cisplatin ineligibility, so PS more than 1, creatinine clearance less than 60, heart failure NYHA grade more than 1, and uncontrolled hypertension, neuropathy, hearing loss more than 1. CTCA versions and symptomatic brain mets because of requirement for forced hydration, severe psychiatric disorders, and more importantly in our Indian setting, absence of caregiver support. If you are talking in terms of carboplatin based unfitness, PS more than 2 and creatinine clearance less than 45, NYHA heart failure more than 2, but we do have some leverage in terms of other issues like uncontrolled hypertension, neuropathy, hearing loss, symptomatic brain mets, even absence of caregiver support. So no absolute restriction for these factors. So in most of the cases, as we just saw, 88% of the cases, a combination of these factors was considered to guide the treatment decision in terms of serious comorbid illness as well. So heart disease, hypertension, cerebral peripheral vascular disease, chronic renal failure, COPD, diabetes. So if you just see one or the other factor of among these would be there in elderly patients, which dictates the treatment journey for that particular patients. So we need to be very clear in choosing our agents. Next slide. So when we look at the randomized data, first line single agent chemotherapy trial data, including the patients deemed unsuitable for platinum based chemotherapy. So these were the agents available to us: gemcitabine, vinorelbine, docetaxel, pemetrexed, and key eligibility criteria related to the platinum unsuitability. We have many what we just discussed. So gemcitabine, vinorelbine, docetaxel, and pemetrexed, with median OS being 9 months, 7 months, 5 months, 4.7 months respectively with these agents. Next slide. Single agent chemotherapy. So when we talk in terms of evidence for single agent IO in NSCLC for patients, which this definitely it is scarce. It is very minimal evidence. So there are no randomized phase 3 trials investigating first line pembro in poor performance status or platinum ineligible patients. And we have something called as PEPS2, pembro in patients with non-small cell lung cancer of performance status 2, This is a single arm phase 2 trial which has enrolled regardless of PD-L1 expression status, enrolled 60 patients, of which 24 patients are first line. So median OS was close to 8 months in first line and PFS was 4.3 months. And we do have Nivo plus IP phase 3 trial ECOG PS2 or who are older than 70 years. So, but the study data monitoring committee halted recruitment because of the high mortality. Nivo plus IP, median OS being 2.9 months. And we do have data with Durva phase 2 SAC 19/17 in patients with ECOG PS2 with PDL1 more than 25%, but unexpectedly this was also halted because of enrollment was stopped because of the high number of the fatal events. Next slide. Yeah, so then comes the trial, topic for discussion today. So IPS was Ipsos study, phase 3 global multicentric open label randomized study, and we do have Indian patients in this phase 3 global trial. So atezolizumab Tecentriq versus single agent chemo in patients who are considered unsuitable for first line platinum doublet chemo. Next slide. So yeah, so these are the results from phase 3 study of first line atezo versus single agent chemo in the patients with NSCLC not eligible for a platinum containing regimen. As we see here, Dr. Kumar Prabhas is one of the PI here. Yeah, next slide. So we do have the Indian patients enrollment in this particular data. Next slide. Yeah, background of this trial being, as we were just discussing, so it's a phase 3 global multicentric open label randomized control study examining the efficacy, safety and patient reported outcomes with atezo versus single agent chemo in patients who were considered unsuitable for first line platinum doublet chemo. Next slide. So this is the study design, squamous or non-squamous histology, platinum ineligible because of ECOG PS2 or 3, PS01 permitted if more than 70 years of age with substantial comorbidities or other contraindications to platinum chemo. And diver mutations EGFR ALK were excluded. Patients with treated asymptomatic brain mets were permitted. So 453 patients were enrolled. They were randomized in 2:1 fashion to atezo versus investigator choice vinorelbine gemcitabine. So till progression. So stratification factors were squamous and non-squamous histology, PDL1 expression levels by SP142 assay, TC3 or IC3 or other TC levels, and the brain mets, yes or no. The primary endpoint is overall survival. So these are the demographics and baseline characteristics, very well balanced between arms of atezo and chemo, and brain mets close to around 9% in each, liver mets 15% to 7 versus 17%. And if you look by PDL1 expression levels by SP263 assay, TC more than 50%, 17% in each, less than 50%, 75% each. Overall, TC1 or more than 1%, 42 versus 52. And histologies, non-squamous 57, squamous 43% of patients. Next slide. So this is the primary endpoint, overall survival at final analysis. So ITT population, median overall survival is 10.3 months for atezo versus 9 months for chemo arms. So hazards being 0.78 and p-value is 0.02. Median follow-up is 41 months. Next slide. So hazards are 0.78 significant, and the OS benefit is associated with atezolizumab was consistent across all key subgroups irrespective of ECOG PS as well as histology as well as presence or absence of brain mets and liver mets and number of metastatic site, and most importantly PDL1 expression levels less than 1% and more than 50%. Next slide. And this is progression free survival. So median PFS 4.2 months versus 4 months, definitely numerically improved, but hazards being 0.87. Next slide. When we are talking about overall response rate, 17% with Atejo versus close to 8% with chemotherapy, roughly delta being 8.9% higher with Atejo. And when you look in terms of CR and PR rates, I mean, more likely we look in terms of disease control rates, 57% versus 56%. Next slide. So, as we just heard, these are all elderly patients unsuitable for cisplatin platinum doublets. So, the patient reported outcomes play an important role. So, Atejo arm remained stable less than 10% across all domains, while chemo arm showed some deterioration in some domains. So, role function, cognitive function, definitely improvement with Atejo, and social function also improvement with Atejo over chemo. Next slide. And so these are the improvements in atezolizumab arm, cough and chest pain. These are the two components which have shown improvement in atezo arm, and peripheral neuropathy and alopecia deterioration in the chemo arm. There is one thing, insomnia, which has been shown to be having some kind of mild improvement in chemo arm, and of course the appetite loss is also this improvement in atezo arm and deterioration in the chemo arm. Next slide. So as we just discussed, time to confirm deterioration in terms of chest pain better with Atejo, and symptom wise fatigue, dyspnea, arm pain, shoulder pain, cough, dyspnea, all were better for the Atejo. Next slide. So if you look in terms of the median treatment duration, 3.5 months versus 2 months versus 1.8 months, and median number of cycles initiated 6 versus 4 versus 3, and all grade adverse event, treatment related adverse events, 57% with Atejo versus 80% with chemo. Grade 3, grade 4 adverse events, treatment related, 16 versus 33%, and serious adverse events, 11 versus 15%, telling us that Atejo fared better and it caused less adverse events. Next slide. When compared to chemo in this population group. Next slide. Next. Yeah, next. Yeah. So when we talk in terms of immune mediated adverse events, immune mediated hepatitis, hypothyroidism, pneumonitis, hyperthyroidism, diabetes mellitus. So definitely when we use immunotherapy, expected to have more immune related adverse events, but not very high. Next slide. So empowering the ineligible, 75% of the patients in this study is ECOG PS2. That's what we need to remember. Treatment option for ECOG 2 who would otherwise be considered too frail for standard chemo. And most of the times we do face this situation in real time, and they will be pushed for the best supportive care. And the treatment option for the patients with a reduced renal function, definitely yes, again this serves the purpose, single agent Tecentriq, and 73% in this were more than 70 years. So and 30% were more than 80 years. So if you look on a real time basis, I think single agent Tecentriq did really good. Next slide. Yeah. So this is incorporated in the NCCN guidelines as an option for PS3 patients regardless of PDL1 expression, and ESMO guidelines as Atejo monotherapy can be considered for patients ineligible for platinum based chemo due to PS2 or more than 2 or age more than 70 with comorbidities regardless of PDL1 status. Next slide. So the conclusions being, first line Atejo significantly improved OS over the single agent chemotherapy, hazards being 0.78, and deemed ineligible for the platinum doublet chemo. Benefit is seen across all key subgroups like patient's age, histology, PDL1 expression level, and ECOG-PS. 2-year OS rates are nearly doubled with Atejo, 24% versus 12%. Overall response rates are higher and more durable responses, 14 months versus 7.8 months, and it was associated with maintenance of health related quality of life, and treatment related grade 3 grade 4 adverse events, serious adverse events, grade 5 adverse events occurred in a smaller proportion of patients with Tecentriq when compared to chemo. With that, I would like to end my talk. Yeah, thank you. That's all. If there are any questions, I'm happy to take.
Thank you, sir. Now I would like to invite Dr. Gaurav Kumar. He's a consultant medical oncologist, Tata Hospital, Muzaffarpur. Welcome, sir.
Thank you. Am I audible?
Yeah, you are audible, Doctor.
Thank you. Thank you. So at the outset, I would like to first extend my thanks to the organizers. A wonderful academic program. I was listening to certain topics, very well discussed, and also this type of programs should continue in future also, and we would benefit from this. So I would like to share my slides.
I think Avni can share the slide.
So you can share the slide and give the control to me if this is.
Is my screen visible, sir?
Yeah, yeah. Thank you. Thank you.
Okay, sir.
Can I change the slides from my side?
Sir, you can just say next slide and I'll change it for you.
Okay. So let's continue with our academic discussion. And this was a good paper, Checkmate 816, which was presented in 2025 ASCO annual meeting. And it's basically a paper trial which was done to see the survival with addition of neoadjuvant nivolumab with chemotherapy in patients with resectable non-small cell lung cancer. So one of the first of its kind is add a immunotherapy checkpoint inhibitor with a chemotherapy in resectable non-small cell lung cancer. So I'm going to discuss regarding the final analysis or pre-planned analysis of OS, 5-year OS data for this trial. Next. So coming to the initial key takeaways, this is basically this trial Checkmate 816. This is a pre-planned final 5-year analysis of neoadjuvant nivolumab with chemotherapy, and it has shown a statistically significant and clinical meaningful OS benefit as compared to chemotherapy, standard chemotherapy in resectable non-small cell lung cancer. And as I'm going to discuss in later slides, that Nivo plus chemotherapy continue to demonstrate a benefit in lung cancer patient survival. They have also resulted in durable and long-term event-free survival benefit, and patients had more pathological complete responses with addition of checkpoint inhibitor, that is nivolumab with chemotherapy. And this increase in PAT-CR rates has improved the long-term overall survival as compared to patients who didn't achieve the PAT-CR. So this trial again put more emphasis that achieving a PAT-CR can give a better survival as compared to not achieving a PAT-CR. Again, this trial has also tried to see what's the role of circulatory DNA clearance and is survival associated with it or not. And pre-surgical, the ctDNA clearance was also shown to be associated with improved overall survival, regardless of the treatment received by the patient. Next. So coming to the background, this is basically a phase 3 trial, Checkmate 816 study, where they have tried to see a new addition of neoadjuvant nivolumab with chemotherapy as compared to only chemotherapy in resectable non-small cell lung cancer, and it has shown statistically significant advantage both in event-free survival as well as improving the PACR rates in patient with resectable non-small cell lung cancer. And if you see the hazard ratio of event-free survival, that is a good 1.63, and PACR rate of 24% as compared to only 2% with chemotherapy. So there was a huge jump in terms of PACR rate with use of nivolumab addition with chemotherapy, and that has also not only the improvement in PACR rate, it has also translated into improvement of event-free survival. So nivolumab with chemotherapy, basically it's as I mentioned, it's first of its kind, sole neoadjuvant chemoimmunotherapy regime, which has been approved in multiple areas, multiple countries, including United States and European Union and other countries. And this is basically a pre-planned final analysis of OS from Checkmate 816 study after a minimum follow-up of 5 years. Next. Coming to the study design of Checkmate 816, eligibility criteria, all the resectable non-small cell lung cancer with stage 1B to 3A were included in the study. Patients of good performance status were included, and patients should not have a sensitizing EGFR or ALK alterations were only included in the study. And they were stratified based on the stage of the disease by the PD-L1 levels and sex of the patient. And they were randomized into 1:1 ratio. One arm was nivolumab 360 milligram every 3 weekly with chemotherapy 3 weekly for 3 cycles versus chemotherapy alone 3 weekly for 3 cycles. And radiological restaging were done after planned treatment, and surgery was planned within 6 weeks of treatment. And adjuvant chemotherapy or radiotherapy was optional and was based on basically the treating physician's discretion. And a median follow-up of 60 months, 68.4 months was there. Primary endpoint was first PACR rates, then event-free survivals. Secondary endpoint was overall survival, and exploratory endpoints were overall survival based on PACR rate, based on ctDNA clearance, and lung cancer-specific survival were other exploratory endpoints. Next. Coming to the statistical analysis plan, they've tried to see if initially if PACR was significantly increased with addition of this drug or not. And if the PACR improves and it becomes statistically significant with nivolumab and chemotherapy, then they have planned to see for event-free survival. And if PACR and event-free survival both were found to be significant, then the OS was tested hierarchy with two-side type 1 error of 5%. So OS final analysis was specified at to occur at 185 events or a minimum 5 years of follow-up. Next. Coming to the final analysis of OS with neoadjuvant nivolumab plus chemotherapy versus chemotherapy alone, and we see median OS has still not reached with nivolumab plus chemotherapy, and it was 73.7 months with chemotherapy. So the graph itself speaks about what's the magnitude of benefit that addition of nivolumab with chemotherapy has given as compared to chemotherapy alone. So at 5 years, you can see 65% of patients in nivolumab chemotherapy arm were surviving as compared to 55% of patients in chemotherapy arm. So a roughly jump of 10% with addition of nivolumab at 5 years. 10% more patients were surviving with the nivolumab addition. Next. Subsequent anti-cancer therapy is important since we are using nivolumab with chemotherapy in first-line setting. So we do expect to see more and more patients once they recur or relapse, they will get more and more chemotherapy. But in chemotherapy arm, many patients, since they were immunotherapy naive, so they had on after relapse or recurrence, they go on to receive immunotherapy. That is 27% of patients in chemotherapy arm receive subsequent immunotherapy. EGFR, ALK, inhibitors were almost equally received in both the arms. And if we see on disease progression and recurrence, more patient in chemotherapy arm receive subsequent systemic therapy as compared to nivo and chemotherapy arm. Next. Coming to this important plot where you can see based on different subgroup analysis what's the magnitude of benefit that nivolumab has given as compared to chemotherapy alone. You see almost all the subset of patient has all subgroup of patient has benefited with the addition of this drug, but notably the stage 3 patients, that is the stage 3A patients, they have achieved a better benefit. If we see based on PDL1 status, the positive PDL1 patients have achieved better benefit with nivolumab addition as compared to chemotherapy alone, and almost all the subgroup, be it cisplatin or carboplatin or based on the racial factor, based on the origin of country, almost all the subgroup has benefited with addition of nivolumab to chemotherapy in neoadjuvant setting. Next. Coming to the OS at baseline, based on the baseline stage of the disease, we see both stage 1B, 2 or stage 3A, both the group of patients have responded nicely to nivolumab with chemotherapy and have shown benefit, but the magnitude of benefit was higher in higher stage patient, as I was speaking in my last slide also. Stage 3A patient achieved or they got more benefit with addition of nivolumab but with chemotherapy, and stage 1B and 2 patient also have benefited with addition of nivolumab with chemotherapy in neoadjuvant setting. Next. Again, OS by tumor PDL1 expression, as I have already mentioned, the magnitude of benefit was very much high when PDL1 was found to be positive, and median OS was still not reached with nivolumab and chemotherapy arm as compared to 73.7 months with chemotherapy alone. And if you see at 5 years down the line, almost 20% extra patients are surviving with addition of nivolumab and chemotherapy in PDL1 positive patients. So the magnitude of benefit was very much high in patients who are PDL1 positive. Next. Lung cancer specific survival, again, addition of nivolumab with chemotherapy in neoadjuvant setting of resectable lung cancer, they have achieved a better lung cancer specific survival as compared to chemotherapy alone. But in both the groups, the median lung cancer specific survival was not reached. An unstratified hazard ratio was 0.65, which is actually a very good hazard ratio for this kind of trials. Next. Event-free survival at 5 years of analysis, we can see median EFS was 59.6 months with nivolumab chemotherapy versus only 21 months with chemotherapy. And 49% of patients remained event-free at 5 years when nivo and chemo was used in neoadjuvant setting, as compared to 34% patients remained event-free with help of chemotherapy alone. So again, there is a leap or jump of 15% patient who were remained event-free, extra patient, 15% extra patient who remained event-free at 5 years with addition of nivolumab in neoadjuvant setting. Next. Coming to the exploratory analysis, that as I have mentioned initially, that they have tried to see certain exploratory endpoints with the OS, is the OS was related to PACR rates or not. Again, if you see the graphs, the green one is for nivo chemo and the gray one is for chemotherapy. Patients who have achieved the PACR, their survival was always better as compared to patients who hadn't achieved the PACR, be it in a nivo chemo arm, irrespective of the treatment received. If they have achieved a PACR, their survival improved as compared to patients who hadn't achieved a PACR. And among the patients who had PACR, death occurred in 3 patients, and none were due to disease. And a patient who have not achieved the PACR, 46% of patients had deaths, and out of that, 33% patients died due to the disease. So again, at least in lung cancer, we can, based on these trial results, we can confirmly say that okay, OS is a bit dependent upon achieving a PACR. Next. Another EFS, if you see event-free survival based on the PAT-CR status, again, we can see in both the group of patients, event-free survival was also affected with achievement of PAT-CR. The patient who have achieved the PAT-CR, be it irrespective of the treatment received, they had a better event-free survival as compared to patients who didn't achieve the PAT-CR. Coming next slide. Going to the second exploratory analysis, that is the OS by ctDNA clearance. Again, a very wonderful endpoint to be noted, and I was very happy to see the trial has included this endpoint, because the ctDNA clearance has come up in a very big way, not only lung cancer but other cancers like head and neck cancers also. And people are trying to see, doctors are trying to see that is the clearance of ctDNA is somehow related to improvement in OS and event-free survival or not. Again, this trial has shown that that if a patient who has a baseline circulatory DNA present and it gets cleared, irrespective of the treatment received, they have a better survival, long-term survival, as compared to patient whose DNA clearance has not been achieved. So again, these exploratory endpoints again shows a positive trend that circulatory DNA is a good prognostic marker. Clearance of circulatory DNA is a good prognostic marker, and it can give us a hint regarding what the patient is going to have in terms of survival in long-term setting. Next. Safety summary, not much different. Whatever we see in this table is very much known to each and every one of us, that nivo chemotherapy, the side effect profile, mainly the grade 3 core toxicities, was almost similar and was more and more attributable to the chemotherapy arm on both the groups. Except for certain immune-related side effects, which were expected to be higher with the use of nivolumab, endocrinopathies, and skin reaction. But the good thing is treatment discontinuation rate due to adverse events were more or less similar, and the addition of nivolumab with chemotherapy had not caused increased treatment discontinuation rate, which is a concern for us, for doctors, when we are using a doublet or when we want to add a drug in neoadjuvant settings. We always want our treatment to complete. Patient should complete the treatment to achieve the best possible result. And nivolumab had not caused increased treatment discontinuation rate. Next. Coming to the summary, it is the pre-planned final 5-year analysis of Checkmate 816, where the neoadjuvant nivolumab with chemotherapy demonstrated a statistically significant and clinically meaningful OS benefit versus chemotherapy alone. 5-year OS rate, as I mentioned, 65% with nivo chemo as compared to 55% with chemotherapy arm. Nivo chemo also improved lung cancer specific survival as compared to chemotherapy alone. And as I mentioned, the exploratory endpoints, PCR rates were associated with improved overall survival. Pre-surgical ctDNA clearance was also associated with long-term OS improvement. Safety profile was not a concern with addition of nivolumab with chemotherapy, and it's a well tolerated regimen. And chemo, as I mentioned, Checkmate 816 is one of its kind phase 3 trial in neoadjuvant setting, which has tried to see chemoimmunotherapy, has shown a statistically significant OS benefit in resectable solid tumor type. And this trial can be practice changing in terms of treating patients with resectable non-small cell lung cancer who has not got any actionable genomic alterations. Next. So I think that's all from my side. I would like to thank all my audience for patience listening. Over to you, and I would be happy to answer any questions and doubts if there.
Yeah, thank you, Dr. Gaurav. That was a good talk, nice talk. So, I mean, when we are talking about resectable NSCLC, so with Checkmate, this Nivo plus chemo, PAT-CR is close to 25%. That means essentially out of 1/4 of all the patients had PAT-CRs. So that itself shows, and it is the first positive neoadjuvant trial, IO trial. The only question, I mean, I was asking the previous also. I also didn't have any challenges with neoadjuvant IO use. Do you have any issues over the I mean, during the point of surgery, any discussion with surgeons, if you have?
I think for lung cancer patients, I have not used Nivo in too much in neoadjuvant setting, but other cancers like head and neck, we are using nivolumab in many patients. There have been studies going on for nivolumab neoadjuvant setting, and my surgeons, I don't think they have any issues with addition of nivolumab with chemotherapy, in terms of their morbidity, surgical morbidity or mortality. So they are very much comfortable with this regime, and I also find that uh, this this addition of checkpoint inhibitor, mainly nivolumab, is a fairly well tolerated drug, and the toxicity profile, if it happens also, is well controllable, well manageable, and doesn't lead to any sort of discomfort to our surgeons during surgery.
Yeah, I agree well with you, whatever you told, right? Thank you.
Thank you.
Yeah. Yeah. Back to organize.
Thank you, Dr. Gaurav. So our next speaker is Dr. Sai Krishna. He's a consultant medical oncologist and BMT specialist, American Oncology Institute, Vijayawada. Welcome, sir. I would also request the tech support team to stop the recording for now.
Yeah, can you share?
Apollo Hospitals, Jubilee Hills, Hyderabad. Welcome, sir. I would request the tech support team to start the recording again.
Can you please kindly share the slides? First, I would thank Dr. Venu sir and AstraZeneca for this opportunity, and also salute Venu sir for conducting such a long conference very patiently.
Thank you. Thank you, Srinath.
I hope my screen is visible, sir.
Yeah. So again, disclaimer slides are by AstraZeneca. Next slide, please. So liver cancer is the seventh most common cancer and fourth most frequent cause of cancer-related deaths globally. Next. 45% of the cases diagnosis liver cancer as peripheral lymph nodes or metastases, and the prognosis is overall very poor. And we all know that unless we do a liver transplant and we're able to resect and it falls under the criteria of resection and transplant, there is no cure for this cancer. Next, please.
Next slide.
Sorry. One second. Yeah, sorry. So hepatocellular carcinoma in India. India is the 11th most common cancer type and 8th most common cancer related common for cancer related deaths. And I am so sorry. Disturbing actually, but just a moment, please. Yeah, so sorry. And the median age is around 40 to 70 years and increases with increasing age. And incidence of HCC in cirrhotics in India is 1.6% per year. And we know that majority are do present to us in advanced stages like BCLC and D. Next, please. So inflammation and immune dysregulation are the key contributors leading to HCC development, and the chronic infection with HBV, HCV, and non-alcoholic steatohepatitis or alcoholic steatohepatitis. They lead to chronic inflammation, cirrhosis, cell death, and deregulated liver immune network, immune suppression, exhaustion, and missing tumor surveillance, proliferation, and pre-oncogenic transition. Multiple mechanisms of immune escape we all have discussed in detail. Overexpression of CTLA4 and PDL1 and inhibition of antigen presentation contribute to the entire boxes. Next one, please. So risk factors: viral, HPV, HCV, alcohol, tobacco, and aflatoxins, NASH, non-alcoholic fatty liver disease, obesity, and diabetes. It's epidemic now in India and all over the world. We know that. And male sex specifically predisposes, and autoimmune hepatitis can also sometimes definitely lead to HCC. Next, please. Next slide. So now we know that beyond the viral and alcoholic etiology, the non-alcoholic fatty liver disease is the most common cause of cirrhosis, and HCC. The rate has definitely increased now. Next, please. So how do we manage unresectable HCC? Next, please. This is a very popular slide we all know, and our topic of interest is advanced stage C and D. We'll proceed with the standard management of this particular stage, BCLC. Next, please. So evolution of systemic treatment, sorafenib was the first molecule, then lenvatinib showed non-inferiority, and then came the blockbuster data of Vetizo-Bev and Nivo-EP, and then came second-line treatments, regorafenib, cabozantinib, and ramucirumab, and the latest being tremelimumab and durvalumab combination. Next, please. So as we discussed, roughly with the sorafenib or lenvatinib, roughly 1 year is the overall survival, and that's what we see in practice. Very difficult, TKS are usually very difficult drugs to tolerate, and especially in the background of cirrhosis and all, people have a lot of side effects. Next, please. So IO plus anti-VEGF combination has shown very good results compared to only anti-VEGF inhibition. Next, please. So IMRAVE trial, we all know that it compared Atizo-Bev with sorafenib, and next, please, has shown significant overall survival and PFS benefit with 19.2 months and versus 13.4 months in the TKI group. PFS being 6.9 versus 4.3 months in the in the sorafenib group, and the HR for OS is 0.66. Next, please, which is statistically significant. So the flip side of this agents is, one, it works very well in viral HCC, but in non-viral HCC was not it didn't show so much of a benefit, and also very difficult to use regimen when especially high risk bleeding viruses are present in the background of cirrhotic liver. Next, please. So the most common immune related adverse events are hypertension and proteinuria mainly, and again makes a difficult combination to use it in people with uncontrolled hypertension or cardiovascular disease and chronic kidney disease. Next, please. So what is the alternative? Is a dual immune checkpoint inhibition, IO plus IO, because VEGF is the major cause for all those effects. Next, please. So rationale for combining anti-CTLA4 and anti-PD-1 has been, I think, very well elucidated by my previous speakers in the combination of nivolumab and ipilimumab in various cancers. And there's a slight difference between Nivo-EP and Durva-Tremi, which we will discuss in the coming slides. Next, please. So Durva-Tremi, again, the same way, one is a recruiter, that is regulator of T cell activation and the lymph nodes, and basically the tremelimumab, kind of brings in a lot of new T cells into the tumor, which precisely the VEGF inhibitor also did, and also it kind of brings in a lot of heterogeneous T cell population. And the role of durvalumab is blocking PD-L1 and reversing the T cell exhaustion, or basically it keeps the T cells active in the tumor microenvironment so that the tumor kill is active. So I think this mechanism of action is what gives us the tail with the immunotherapy, because of the recruitment and also the maintenance or activation and maintenance by PD-L1 blockade. Next, please.
Again, same thing when we see the peak here, a single dose of tremelimumab just shoots up the number of CD8 T cells in the tumor, and the durvalumab by PD-L1 blockade keeps them active and keeps them active for tumor killing, and that gives us a sustainable response. So the point is of combining CTLA-4 with PD-L1 is to get this peak of CD8 T cells. But all the EPILI trials used 4 cycles, but is 1 cycle really effective? We do have data that single shot of tremelimumab is effective. Next, please. So the study 22 evaluated 4 combinations. That is the stride tremeli single dose plus durva plus tremeli 4 cycles versus single agent durva and durva bev. Next, please. Amongst all the combinations, the stride combo, that is 300 mg tremeli and durva gave the highest median OS in this particular study and was more than or equal to 3.6 months longer than all the other treatment arms. In addition, the one event observed at only one event was observed at 27 months, and stride regimen demonstrated an a clear balance between acceptable safety and required T cell recruitment. Next, please. So this is a phase 3 Himalaya trial, which again tested the stride regimen. Next, please. Stride versus single agent durva versus sorafenib. It's basically a 3-arm study. Next one, please. So the dosing again 1500 mg durva every 4 weekly versus a single shot of tremelimumab 300 mg single priming dose. Next one, please. So baseline characters are well balanced, and the virality and non-viral etiology were equally included, and majority were BCLC-C and Child-Pugh-A, and PD-L1 positive were around roughly 1/3, and majority is rest of the world. Asia excluding Japan is around 40%, and median age is around 65. Next, please. So subsequent second-line anti-cancer therapies in the trial were also less when durva-tremi combination was used compared to single-agent durva or sorafenib. So it just suggests that the patients had a prolonged response, and the need to switch to second-line anti-cancer therapy was a bit less. Thank you. Next, please. The slide demonstrated statistically significant improvement in median overall survival, and you can see the curves slowly separating around 4th, 5th month and remain separated till around nearly 3.5 years. So with the 3-year OS being around 30% versus 20% in the comparator sorafenib arm. And the median OS is roughly 16.4 months versus 13.8 months, and the HR hazard ratio is 0.78. Next, please. So when we see in the non-viral etiology also, it did equally well compared to the viral etiologies. That is the major advantage of a dual IO regimen, especially when we have already seen the data that NAFLD has been the leading cause of cirrhosis and HCC these days. So this scores positively compared to the atezo-bev combination. Also, this is a good alternative for patients with uncontrolled varices secondary to cirrhosis or any cardiovascular disease or CKD. I think this will be a very good regimen. Next, please. So the ORR, you see it is around 20% versus 5%. There's a 15% difference in ORR. And also the duration of response is quite longer for 22 months versus 18 months in sorafenib arm. Next, please. Treatment-related adverse events were also quite less compared to sorafenib, and even the hemorrhage, if you see, it's roughly only grade 3, grade 4 hemorrhage is only 0.5%. Next, please. So again, most common were rash, pruritus, and diarrhea, unlike hypertension and proteinuria in Eltizobeb study. Next, please. So treatment related hepatic or hemorrhage are obviously less. We discussed that. And esophageal varices hemorrhage is 0. Next, please.
So, Dr. Shenaz, a great presentation. Can we request to conclude with your take-home message, please?
We're almost near the conclusion. So, strident durvalumab monotherapy represent the potential new treatment options for unresectable HCC. And as we discussed, the advantages and disadvantages, this is definitely a very good regimen for people who cannot take atezolizumab and bevacizumab. Over to Dr. Venu, sir. Thank you, sir.
Yeah, nice presentation, Dr. Srinath. So basically, yeah, child puke unresectable HCC stride is good regimen, especially when you want to avoid bevacizumab particularly. That's one. Apart from that, we also know that only priming dose and then avoid continued CTLA4 associated toxicity. Only give one shot and go ahead for continued PDL1 blockade. I think it has its own bright future in the management of HCC. So with that, yeah, anything, Tarunji, I will conclude my talk from my end.
Yes, sir. Your takeaways, and then we say goodbye to everyone. Please, over to you for your closing remarks.
We heard a good talk from all of our speakers and good moderator discussion on breast cancer. And I would like to thank all our academic partners, Astra, BMS, Novartis, Roche, Jadis, Sun, Intos, Mankind, ADMAC, Celon, and Lupin, without whose contribution definitely it's not possible to conduct. And I would, at the same time, I would like to thank Tarunji and other Avni Horizon for conducting this event in a great way, and hope to conduct many more. Thank you all.
So thank you so much, Dr. Venugopal sir, on behalf of my colleagues Avni and Dawood. Thank you so much for this opportunity. Apologies for being late. I think we're almost all an hour late. Sorry for this, and hope you enjoyed this and have a great weekend. And see you next time. Till then, goodbye and stay safe. Good night, everyone. So Avni and Dawood, you can close the meeting. Thank you so much. Thank you so much. Good night, sir.
Thank you, sir.
Thank you all. Good night.